for a short time. They have to leave us a little bit early, but we're happy you're with us now. And Melissa Parisi is taking a work-related phone call, but will join us as soon as that's over. So do you want to take us through roll call?
Welcome back, everyone. I will go ahead and start calling from Agency for Healthcare Research and Quality, Kamala Mystery. No, actually, if you don't mind speaking into the microphone.
Here.
Thank you. Kyle Brothers,
Here.
Ned Kalange
I'm here.
from Centers for Disease Control and Prevention, Carla Kufner,
I'm here.
Janine Cody. Jane DeLuca
Here.
from Food and Drug Administration, Kelly Count.
Here.
From Health Resources and Services Administration, Michael Warren. I know he's online, so. Okay. And Jennifer Kwan,
Here.
Ash Law,
Here.
Sean McCandless,
Here.
from National Institute of Health, Melissa Parisi, who stepped out momentarily, and Shanika Fampuco.
Here.
Thank you. I will
This is
call on
Jane
our
Cody.
organization.
I am here, but I wasn't allowed to turn off my mic when you call my name.
Sure, we can hear you now. Thank you, Janine.
Thank you.
And same thing for me. This is Michael Warren.
Thank you. All right, from American Academy of Family Physicians, Robert Ostrander.
Here.
From American Academy of Pediatrics, Deborah Frindenberg.
Here.
From American College of Medical Genetics, Mark Williams.
Here.
From Association of Maternal and Child Health Programs, Karen Downs. From Association of Public Health Laboratories, Susan Tanksley.
Here, sorry, took me a while to unmute.
Thank you, Karen.
House is here.
Thank you. Thank you, Susan. From Association of State and Territorial Health Officials, Scott Schoen.
Here.
From Association of Women's Health and Obstetric and Neonatal Nurses, Shakira Henderson. Okay. Child Neurology Society, Margie Ring.
Here.
You. And representing Department of Defense, Jacob Hogue.
Here.
From Genetic Alliance, Natasha Bonham.
Here.
From March of Dimes, Siobhan Dolan.
Here.
National Society of Genetic Counselors, Kate Walsh-Falkley.
I'm here.
And from Society of Inherited Metabolic Disorders, Gerald Berry.
Here.
Thank you. And I will just give a quick reminder for our organization representatives and committee members, please do not use the chat feature in the Zoom. And for those who are in the meeting, please make sure that your computer speakers are off. Thank you.
Thanks, Ian. Earlier this year, MCHB released the Blueprint for Change, a national framework for a system of services for children and youth with special healthcare needs. This was the culmination of nearly 2.5 years of effort, collaboration with people and organizations across the country, including CYSC, HCN, and their families, consumers, healthcare professionals, public health leaders, researchers, and academic institutions. The Blueprint serves as a national framework to improve the lives of children who have special healthcare needs and impacts nearly 1 out of all 5 children, including newborns and children impacted by heritable disorders. Committee members and organizational representatives all received a copy of the pediatric supplement articles introducing and describing the Blueprint. And more information on the Blueprint and links to the articles can be found on the MCHB website. I'm really pleased that as we start the second day of our meeting, which just has, a couple of agenda items in terms of talking about work groups and solutions and moving forward, We also have the privilege of hearing from Dr. Dennis Kuo, who served on the steering committee for this work and is the lead author on this critical area of access to care. Dr. Dennis Kuo is a professor of pediatrics and chief of developmental and behavioral pediatrics at the University of Rochester Medical Center and the Golisano Children's Hospital. He received his medical degree at the University of Pennsylvania and completed his pediatric residency at the University of North Carolina Hospitals and a fellowship in general academic pediatrics at the Johns Hopkins University. Dr. Kuo has a long-standing interest in the care of children with disabilities and medical complexity, including systems of care, early childhood, and health equity. Dr. Kuo is the immediate past chair of the Council on Children with Disabilities for the American Academy of Pediatrics, and I'm really pleased that you're here to talk about the blueprint. Thank you.
Okay. Oh, very good. Okay, very good. Good morning, everyone. Thank you. This is really incredible treat for me to be here today. Whoop, hang on. I don't want to get ahead of myself here. What did I do? Okay. Okay. I think while we're waiting for the slides, let me give you a little bit of background of the way I've been thinking about the area of the blueprint and systems. My career is really, I mean, if you follow my CV and my career, it's really kind of gone like this. And there actually is a common theme to everything I do, which is the children and the families and the communities where we serve. And I think when I came out of residency, I started out in several years in private practice. And those years, I remember looking at what I was doing and thinking, you know, I could, for example, do something as simple as prescribing a medication, like let's say an antibiotic for an ear infection. And I had no guarantee that that antibiotic would make its way into the child. And of course, it would encompass everything from transportation to health literacy to whether it was even the right decision at all, because a lot of ear infections just go away by themselves. And when we think about our children who have disabilities and medical complexity, the system just gets much more complicated. And there's so many twists and turns and contexts that we have to think about. And that really led me on my journey to where I am today. And every now and then I pinch myself to think that I'm part of this discussion. So this really is a privilege, and thank you for allowing me to be here today. We have objectives, of course. We'll talk about the system of care for children and youth with special healthcare needs, something that I've been looking at from academically and then in partnership with many colleagues for years, and how that relates to the context of newborn screening. We'll introduce the blueprint for children and youth with special healthcare needs, the implication of the blueprint on the care system, and the potential implications for newborn screening and the recommended universal screening panel. Now, when we talk about system of care, I think it's important to understand like what a system really is. It's not just the components that make up what the system is. You know, it's also the philosophy that underlines the system and the journey and the pathways through the system. So we have to think about the system as a journey and a longitudinal pathway through how you get from here to there, when you get from here to health and wellness. And that's important because that's really the context of framing. You know, when we talk about the blueprint, there are principles that underlie everything that we do. I want to give credit to Treby Brown and Sarah Beth McClellan from HRSA, you know, for their partnership, for their leadership, and also for HRSA for this a number of slides that you'll be seeing today. We also have to start with the Maternal and Child Health Bureau strategic plan. MCHB's mission is to improve the health and well-being of America's mothers, children, and families. And a vision is an America where all mothers, children, and family thrive and reach their full potential. And I think it's important to think about what those words specifically refer to. Full potential is not, say, an absence of disease, you know, and full potential also recognizes that children and health and wellness and, you know, maternal and child health is a journey of health and growth and development. And so it's about how do we achieve that maximum potential, not just how do we get rid of disease or ameliorate disease. The goals are access, equity, capacity, impact. The access is to have access to high quality, equitable health services to optimize health and well-being for all MCH populations. Equity is to achieve health equity for MCH populations. Capacity is to strengthen public health capacity and workforce for MCH. And the impact is maximize impact through leadership, partnership, and stewardship. And one thing I also want to note in the goals is how the goals all interrelate to each other. And that's also a principle that we adhere to when we develop the blueprint, is just how all these pieces do fit with each other. So a definition of children and youth with special healthcare needs. They are defined as children or youth who have or are at increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required for children generally. So note that this definition encompasses need, it encompasses services, it does not encompass specifically a diagnosis or a specific condition. And that is for two reasons, two primary reasons. One is that there are children who don't have a specific diagnosis, and yet they have special healthcare needs. The second is recognizing that across different needs and diagnostic conditions that families and communities encounter many similar issues related to navigation, related to service type that they need, related to the stress that families and communities feel when they encounter the service need, trying to get to the point of maximum health and wellness. The definition of children with special healthcare needs does encompass a very wide range of conditions and needs. So on the more milder service need might be the child with a relatively uncomplicated asthma, and that child would do well with a controller medication, the occasional scheduled visit with the primary care doctor, and adhering to NHLBA guidelines. On the more complex end, you might have kids who have spina bifida who require multi-specialty care, more of a complex care approach, and also a set of related services through the education, financial, and community support system. It's also important to recognize that the definition encompasses a number of behavioral and developmental diagnoses. ADHD and cerebral palsy is within there. Genetic diagnoses, including Down syndrome, which can result in a number of complex care needs. Under the recommended uniform screening panel, many of the conditions that we screen for and have added to the recommended panel over the years would fall into this category. So metabolic disorders, endocrine disorders, including hypothyroid and congenital adrenal hyperplasia, sickle cell disease, critical congenital heart disease, cystic fibrosis, hearing loss, and severe combined immunodeficiency. Again, this is certainly not an exhaustive list of everything that's recommended or screened for, but we can see how these particular conditions do result into the care needs that would fall under the system of care for children with special healthcare needs. Now, when referring to the charters and the principles that we operate under for this particular group, the recommended uniform screening panel we're asked to look at conditions that are chosen based on the potential net benefit of screening, the ability of states to screen for the disorder, and the availability of effective treatments. And there are testing goals that when you look at what it could result in, it's if you can get the testing done very early on within the first 48 hours of life, and then report it to the newborn's healthcare provider within 5 to 7 days of life, the thinking or the impact would be that by proper diagnosis and treatment under the life course model, that you can have a very long-term impact on the child's health and wellness. But it is important to also recognize that the charter does also state the follow activities, including those necessary to achieve best practices and rapid diagnosis and appropriate treatment in the short term, and for us to consider those that ascertain long-term case management outcomes and appropriate access to related services. So that part, long-term case management outcomes and appropriate access to related services, that is a world that I've lived and practiced in, and this is why I appreciate the opportunity to come discuss the blueprint. And I really maintain that almost all the conditions that we screen for result in special healthcare needs, because it does not, the journey, and I use the word journey deliberately, does not end with the diagnosis. With many of the conditions, there are chronic care and ongoing specialty care management needs. There may be medications, there may be formulas, special diets, there may be therapies necessary. Even with early diagnosis, we may be looking at physical occupational speech therapy, for example, to be able to ameliorate or not just to reduce the risk of a disease condition, but also to make sure the child reaches their maximum health potential. There's also the need for early and continuous screening for comorbidities, including learning difficulties. And as we enter the world of critical congenital cyanotic heart disease, there's more and more literature about the learning and difficulties that many children that we encounter as they start to go through the education system. And because of this, we maintain that children with special health care needs are best served by a comprehensive system of care. And I've mentioned that the system is not just the components like your specialists and your primary care and your schools and your financing system, but it's also how kids get through the system, the journey of the system, and the philosophy of care that underpins the system. And I also posit that we need to be looking at the needs proactively and holistically. Proactively meaning that when you get a realization of a specific diagnostic condition, what is the path forward? You know, for kids who don't have special healthcare needs, who may be neurotypical, who are typically healthy, the journey seems like it's fairly straightforward in the sense that when a child turns 5, they would go to kindergarten. There's an expectation that when the child finishes 12th grade, that there's a pathway of independence ahead. When you have some sort of a special healthcare need, the pathway starts to go this way, and that's what we're trying to address. The Maternal Child Health Bureau has been conceptualizing and looking at the system of care for children with special healthcare needs really for many decades. You know, and this, it's really comes through the long history of the Maternal Child Health Bureau coming through the civil rights era and look and the involvement of children's families and family advocates who really advocated for the health and wellness for all children with special healthcare needs. The 6 indicators of well-functioning system that's been used for really several decades at this point, and we are still using this system for measurable outcomes, is presented here with the underpinning and foundation of family-centered care and cultural and linguistic competence. And we place individuals and families in the middle because they are the center of the system. And you can see the 6 components, which again, there are metrics that we look at that often are, we take these metrics from the National Survey of Children's Health. Starting from the top and going clockwise, families as partners, the medical home, adequate insurance, early and continuous screening, community-based services, and transition to adulthood. And on this slide, we'll go through just what do these components mean. So families as partners means that our system encourages and builds in that families are partners in decision-making at all levels. And all levels mean at the individual level, but partners also at the system level. And that includes organizational and policy levels, just to give you a few levels. The medical home meaning comprehensive, coordinated, continuous care that is also comprehensive. It should be culturally responsive care, just comprehensive medical care that's provided to the child with special needs. Adequate insurance that is able to cover and pay for the necessary services to achieve health and wellness and potential, also in a way that the family can afford. Early and continuous screening. And we talk about early continuous screening for special healthcare needs. I will also add that when a child has a special healthcare need, the early and continuous screening does not end. You know, there's more screening that needs to be done for things like depression, anxiety, other mental health conditions or comorbidities that may arise. Community-based services that are organized so families can use them easily. And I would also say proactively. So like when we refer to early intervention, special education, we refer to care coordination, that we make sure that the families get the help that they need, as opposed to, you know, here's a phone number to call and then the family reaches a dead end there, because that does happen. And transitions to all aspects of adult life, including healthcare, work, and independence, so that when our children reach the ages of 18 to 21, that they transition seamlessly and effectively into the adult healthcare system and the adult legal system. The context of all this that relates to the newborn screening system is that when we screen and we identify that the system the special healthcare needs really starts to kick in. And I think it's a good opportunity to review what we call the life course approach. And I find often that the life course approach, I think folks heard about it, they know about it, but there's a lot more than saying that, when something impacts a child's life over here, that there's an impact down the line. The life course is really a complex adaptive system, and that things that happen at a certain child's age, that yes, it does have impact down the line. It's not necessarily a linear process. The timing makes a big difference. Some impacts have larger results down the line than others, but it's also recognizing the impacts of structural and social determinants of health, because when you have, let's say you identify a condition at birth, the system that the child enters will also make a big difference in how the child's health and potential results in. So yes, early diagnosis and intervention does impact the life course, including health, development, wellness, and achievement of potential. But after the diagnosis, we have family education and empowerment. We have the medical home and specialty care that come in to be able to address and treat the condition medically. But there's so many other considerations, such as the communities where the child and family reside, the education, because the therapies are often handled in the education system, and the financing for service access. So there's just a lot of these considerations that we have to look at. In the next several slides, I'm going to present just a few case examples of how the system begins to look for children with special healthcare needs. So in the case of a child with sickle cell disease, kids with sickle cell disease are asymptomatic when they're diagnosed at birth. And that's because at the time of birth, they generally have fetal hemoglobin and not the adult hemoglobin that contains the sickle cells when that starts to kind of kick in sometime in the middle of the first year of life. So while they're asymptomatic, you set up the comprehensive system of care. They all should have that medical home. Many children will get referred to ideally a specialty center run by a hematology service that specializes in comprehensive management of sickle cell disease. The goal is to maximize health, growth, and potential. You have to make sure that they prevent infection, that we prevent vaso-occlusive events as much as possible. We optimize nutrition. We put in plans of care for acute event management, and we screen and ameliorate psychological comorbidities, because things like learning difficulties and mental health comorbid diagnoses present at a higher rate when you have sickle cell disease. Of course, you have to have financing for service access, especially since many of these services do add up in cost. And then when the youth turns 18, that there is a coordinated and seamless transition to adult healthcare system and supports. Hearing screening. Now, hearing screening came in when after I finished residency. And so I saw this system come in while I was a practicing physician. And that is in part because the technology got better, the research got better, and the recommendations came in. And there is, I think we all know, there's the early hearing detection intervention system that's through HRSA, which supports the development of state and territory programs and systems of care to ensure that children who are deaf or hard of hearing are identified through newborn, infant, and early childhood hearing screening, and that they receive diagnosis and early intervention to optimize language, literacy, cognitive, social, and emotional development. Put simply, the earlier we identify and address hearing loss, the better the outcomes in terms of language development and social emotional outcomes. So if you get a child where you identify hearing loss, especially within the first month of life, or ideally less than 3 to 6 months of age, you have your medical home, you have your follow-up timely testing, you get your specialty diagnosis and management. And this is all taking place in the first 3 to 6 months. Your routine screening and follow-up for developmental delays, plugging the kids into the education system, making sure they have everything from their treatment of their medical condition to the acquisition of hearing aids, financing, because some of this care gets very expensive, and then transitioning through the early intervention to the special education system to eventually the adult healthcare systems and supports. Spinal muscular atrophy screening. SMA frequently results in a more complex care need, meaning multiple specialists, technology dependence in many cases, the need for not just the medical home, but having, for example, pulmonary, orthopedics, physical medicine, rehabilitation, GI, nutrition, the access to disease modifying therapy, the need for genetic counseling, the need for educational evaluation services and accommodations. And to be able to, again, set all that up while the child is very young, and to be able to not just prevent infections and hospitalizations, but to make sure the child reaches their potential as much as we can. That is the goal of our system of care. So why the blueprint? There's been a lot of really, really incredible work that has been done by the system, by HRSA, by MCHB. And yet the system hasn't moved enough. And by the numbers, when we look at the National Survey of Children's Health metrics, 86% of families of children with special healthcare needs are still reporting that the system is not well functioning. And a lot of this is still because the system is pretty fragmented. We've got a lot of our components and we've got our mechanisms. We've made so much progress with payments and insurance, and yet the services remain fragmented. Two of the areas where we're still seeing deficits in the National Survey of Children's Health are the medical home, which is that comprehensive coordinated care, and also the transitions from a pediatric to adult healthcare systems. And in addition, we are continuing to see inequities in access, particularly in communities that are under-resourced. And so when we look at this, we also need to acknowledge the foundation and the critical role of families, because when we talk about children with special healthcare needs, we also need to acknowledge that the healthcare needs are also accompanied and really are intertwined with many different service and holistic needs, and that our families are the ones that are able to help visualize and determine what those visions and those goals are. We also have a much more progressive dialogue about the roles of structural racism and ableism and social emotional factors that are impacting health and well-being, including a number of position papers recognizing the research and experience that have come out over the last several years, along with many events, including George Floyd, that has impacted our media discourse in the last several years. So the blueprint, back in fall of 2019, a steering committee was convened of numerous experts, convened by MCHB, and this started before COVID happened. And I remember the conversation where COVID started and we all went to Zoom very quickly. And he said, this national summit, what can we do? And we decided that it was no better time than during a pandemic and a crisis to plow ahead, because we knew that the pandemic was going to really hit our system hard. So we continued to plow ahead. We had the national summit in the fall of 2020, where there were over 150 invited participants who attended. And we'll talk about the focus areas that we started to develop in the coming slides. And in addition to our summit, we also had a public request for information where we received over 70 responses from a variety of stakeholders. And by 2021, we had really the vision and the content, and we convened numerous authoring groups. And we'll talk about those 4 authoring groups, those 4 areas. And that culminated in June of 2022, where we released in a pediatric supplement, Blueprint for Change. So now that the blueprint is out, we're now talking about, with all of our partners, what the blueprint means. I'm glad to hear that folks got the copy of the pediatric supplement. I definitely invite folks to take a look at it. And we have events like the one that we're here at today, where we're talking about the blueprint. What's new in the blueprint is, let's start with in the middle top row, that since we recognize the system needs to continue to move, and we're still keeping the system, like the 6 focus areas of the system are still there. They're good markers. We know we have work to do. We had discussions as to how much of the system is that we're still trying to connect pieces together versus how much of this is that the system and the needs of children have moved. Like our children, like since in the last 30 to 40 years, more and more children are surviving previously lethal conditions. Children demographically have become increasingly diverse in terms of race, ethnicity, immigration, and also, as I mentioned, special healthcare needs and complexity in needs. So in order to really take all of that and push the system forward, we came with 4 independent focus areas that center around the issues that families consider most important to strengthen the system of care. And for me personally, this comes back full circle to just why I went down this pathway in my career. It's because families see the system, and families are the ones that make the system work, because families are the ones living the system. So on the upper left-hand corner, the blueprint is a call for health systems to measure outcomes that are meaningful to children and families. Like, for example, the meaning is not necessarily how many doctor visits they have, but whether the child is able to go to school, is able to enjoy the things that children typically enjoy. Lower left-hand corner, a call to design a system that is built around the needs of children and families, not just a diagnosis or treatment protocol. Again, it's centered around the child and the family's needs, not whether they have diagnosis. In the middle, lower, a call to support a service system that supports access, equity, and integration, and eases the financial burden on families, because special healthcare needs cost a lot of money. A call to address the upstream and downstream factors that prevent children use special healthcare needs from a fair and just opportunity to be healthy. They're all kids. Some kids have increased needs than others, but all kids deserve a fair and just opportunity to be healthy. And in the lower right-hand corner, one of our bottom lines, understanding that if we improve the system of care for children with use of special healthcare needs, all children will benefit. Because we're talking about structural factors that impact all kids, even if they don't quite meet the definition of children who use special healthcare needs. We have children who are at risk. We have children who go in and out of the special healthcare needs classification because they might have something that lasts about 5 years and they outgrow it. Or we have children that enter it because they're diagnosed with lupus when they're 14 years old. But all children will benefit if we look at the system of children who use special healthcare needs. So the blueprint focus areas and vision is that children and youth with special healthcare needs enjoy full lives and thrive in their communities from childhood through adulthood. And the purpose of this, the purpose of this image is to make sure that we recognize children and youth with special healthcare needs with a full life in a community in the center. But we have the 4 focus areas and they're all intertwined with each other. So we'll talk about the quality of life and well-being, health equity, access to services, and finance of services is really the focus areas we want to push our policies discussion for children use special healthcare needs, but they're all intertwined. Okay. So under financing of services, as a reminder, healthcare and other related services are accessible, affordable, comprehensive, continuous, and they prioritize the well-being of children and families. Under health equity, all children with special healthcare needs have a fair and just opportunity to be as healthy as possible and thrive throughout their lives without discrimination and regardless of the circumstances in which they were born or live. Under quality of life and well-being, the service system prioritizes quality of life, well-being, and supports flourishing for children with special healthcare needs and their families. Under access to services, children with special healthcare needs and their families have timely access to the integrated, easy to navigate, high-quality healthcare and supports they need, including but not limited to physical, oral, and behavioral health providers, home and community-based supports, and care coordination through the life course. Over the next few slides, we're going to go even more into the 4 focus areas. And after this, we'll start to talk about how it relates to the system of newborn screening. The vision for health equity, again, is fair and just opportunity to be as healthy as possible and thrive throughout their lives without discrimination. The principles for health equity are that there are structural and systemic causal barriers to health equity, and that we eliminate them, including discrimination, poverty, and other social risk factors. And that sector systems and supports that fund, deliver, and monitor services and supports for children with special healthcare needs are designed and implemented to reduce health disparities and improve health outcomes for all children with special healthcare needs. My additional comment on health equity is that having special healthcare needs, having disabilities, having medical complexity by itself puts a child in an increased risk for for not achieving their health and potential, and the intersectionality of racism, ableism, poverty, of all the social risk factors also interplay into that. And it's unpacking all of this is where we're really discussing with the blueprint. Quality of life and well-being. The service system prioritizes quality of life, well-being, and supports flourishing. So note that here that we're not saying that the healthcare access or the absence of disease is the goal. The goal is that families under the principles, regardless of circumstances, can access high quality, affordable, community-based services that support the medical, behavioral, social, and emotional well-being of the child or youth, the whole family. You know, when we talk about children's flourishing and well-being, we talk about, are children able to do the things that children typically will do? Will they go to school? Can they go outside and play? I mean, these are the things that are important to family, that what families tell us are important for metrics and for principles. Health systems place value in the measurement and use of both child and family well-being and quality of life outcomes and health outcomes. So it's not, when we talk about system care, it's not necessarily about, can we reduce hospital costs? It's about, did we make sure that our children are flourishing and our families are flourishing? Access to services that families, children and youth special health care needs and their families have timely access to the integrated, easy to navigate, high quality healthcare and supports that they need. But it's not just limited to healthcare services, it's also physical, oral, behavioral health providers, home and community-based supports, and care coordination through the life course. And that under principles that they're easy for families and professionals to navigate when, where, and how they need them, that the workforce is trained to meet their needs, reflects the families, communities they serve, and is culturally responsive, and that service sectors increase the ability of children and their families to access services by addressing the administrative and the processes to hinder access. You know, like even if we take something as straightforward as healthcare or school, they're governed by different laws, different training, different providers, different places, and even within systems, you're going, you know, even within the education system, even just something as seemingly straightforward as going from early intervention to special education is a transition where kids get lost. And it's this system, these access to services, making it easier, reducing administrative burdens. These are the things that we're talking about. Financing for services, that healthcare and other services are accessible, affordable, comprehensive, and continuous, and they prioritize the well-being of children with special healthcare needs and their families. And under the principles that the healthcare and related services are financed and paid for in ways that support and maximize the individual's values and choices in meeting needs. And so here we're starting to talk about, like, should we be paying for other different kinds of services such as telehealth that we started to maximize more and more of during the pandemic? Health and social service sector investments address social determinants of health to increase family well-being and flourishing. You know, so it's not just about, hey, did you like pay the physician's visit? It's about, you know, are we paying for other things that ameliorate social determinants of health, such as transportation? Payers and service sectors adopt value-based payment strategies that support families, advance equity, and incorporate continuous improvement by integrating team-based integrated care. And the system of finance right now, because it's so split into different sectors, you know, we're asking when we're visioning what the system looks like, how do we make sure that our payment sectors are aligned or even braided so that we can look at health and wellness as the outcome, regardless of what sector or training that the child services may be located in. So in summary, the blueprint and the 4 focus areas inform research, policy, and programs for systems of care at the federal, state, and community levels. We emphasize care integration, we emphasize health equity, we emphasize family-defined outcomes. And I'm using the term human-centered design because we did discuss something called human-centered design in the access paper. That is placing the family, the family and child family needs at the center and designing and meeting their needs. But it also encompasses the journey and the pathway and making it easy, or when I was learning about human-centered design, we called it pleasurable. One of our family partners at a conference I was in, who works in industry now, but is also a family advocate, said that in their field, they call it a delightful experience. I thought, okay, this is, yeah, I mean, when was the last time you thought about having a child with special healthcare needs and thinking about the experience of going through the system, delightful. But this is where other industries are taking, and this is what we need to be aspiring to. Messaging across our bureaus, our divisions, and our systems, and this is what we're doing right now, is saying, we are talking about journeys, we're talking about lived experiences, we're talking about systems. And so I ask you, how can we facilitate this discussion? What can we do? What can you do as a family, with these 4 focus areas? What can you do as a provider? What can you do as a state program? And what can you do as a healthcare research institution? In the next several slides, I'm going to give some thoughts for discussion for the individual work groups for the committee. And these are just my thoughts when just reflecting on the 4 focus areas. So for the education and training work group, could the blueprint's 4 focus areas influence discussion on the broad system of service partners that we need to be accessing when we're talking about the impact of newborn screening? Can it influence the discussion on health equity and address the systemic barriers of services that exist not just at the point of screening and testing, but also the follow-up? Can it influence the community and family partners for collaboration as we think about the follow-up system for newborn screening, including family health information centers, Department of Education, Department of Health, many of the system partners that work in the realm of children with special healthcare needs? The follow-up and treatment work group, to think about the comorbidities and continuous screening needs that happen when we diagnose a certain condition. I mentioned about cyanotic congenital heart disease and the literature that really discusses the need for continuous screening for learning disabilities as a child gets older. So developmental delay, mental health. I should also mention things like structural determinants of health screening, screening for food insecurity. I think we found that many of our families during the recent formula shortage, that was a huge area of stress. And it was wild because we were just trying to pull out, okay, try this formula, try this formula. I mean, that's the sort of thing that families are encountering. Address systemic barriers to service access. Access to the medical home. We know that there is distribution issues for example, not just the rural urban areas, but even within urban areas, that there are distribution issues for providers who are comfortable taking care of these specific conditions. Health equity and systemic barriers, acknowledging the roles of structural racism, acknowledging the roles of poverty, acknowledging the roles of rural-urban divides, and to be able to address those systemic barriers as we're planning follow-up and treatment. The role of telehealth, the unwinding of a number of the rules and regulations that allow the spread of telehealth and that many of us continue to use in practice. And the importance of care navigation, care integration, and family support. So when I was preparing this presentation, I hadn't yet heard the word delightful used in care navigation. I like it. I think I'm going to start continuing to use that. But I challenge us, how do we make our system easier to get through, not just, like I have this phone number and I'm trying to figure out how to get somebody on the phone to be able to address that issue. We have to make it easy and we have to make it delightful. Laboratory standards and procedures work group, finance and payment. Finance and payment, not just for the testing, but what about any follow-up and the burden that it may be incurring on the family. System access for false positive and negatives, including what about the training and resources for the hospitals? What about the learning collaboratives and data-driven outcomes when you have something like, okay, if you have a diagnosis that requires comprehensive follow-up, and I think hearing screening is something that I have been living through as a provider with children who test positive and require a comprehensive follow-up, and how do we make sure our systems where the data is in different places from hospital to primary care to the state, and how do we make sure that they're all aligned so that it is seamless for the family to navigate through. And that's where I also mentioned a regional oversight, including the hospitals and outpatient providers, and examined service experts for follow-up, because we continue to have large issues with children and families with health equity and access and equity and follow-up. And we have to make sure that when we do our planning, that we address these structural issues. I also mentioned here family support and partners, because when we're talking about navigation, the families are the ones who really understand what that navigation looks like. And so partnering at all levels is how we begin to solve the issues. I want to wrap this up by talking about some personal experiences. And I chose 22Q11.2 deletion, which is not on the recommended panel right now. And on the next slide, I do acknowledge that it was looked at about 10 years ago. And part of the issue, or a big part of the issue, was that the research and the understanding and the follow-up was not there at the time. And so I present this as a question of, can the blueprint influence the direction so that there is better information to make these decisions on? But I chose this because as a practicing physician in private practice 15 to 20 years ago, when I was practicing, a number of newborn screening conditions, both on the panel and in some cases not on the panel, came up. And I've had the privilege of seeing what happens 15, 20 years down the line, because in some cases I kept in touch with these parents. In some cases they found me and just said, my child just turned 18 and this mother found me when her daughter turned 18. So this child was diagnosed. We diagnosed a child at 5 weeks of age when she presented with seizures due to hypocalcemia. I think her calcium was like 5.1, which is really, really low. We did not find a cardiac defect identified when she was hospitalized. We did find immune deficiencies, so she got placed on prophylactic antibiotics. And I became a pediatrician. I was in a small group practice, but families preferred to try to follow up with one person. And I had a lot of discussions regarding specialty care, feeding management. I remember instances. I remember this one instance where the child came in, barely breathing, choking, and we called an ambulance and I rode with her to the tertiary care hospital because even the EMS folks weren't comfortable with the way she looked. I remember sitting there when she was 18 months old and not saying anything, not saying any words, and we were talking about speech therapy and talking about the system. And this was before the American Academy of Pediatrics recommendation for universal surveillance and screening for developmental delays came out. I mean, this was like 2001, 2002 or so. And the idea here was, let's walk together, let's plan out, let's be prepared as much as possible, let's stay ahead of the anticipated needs. And this is what we're trying to build towards, is to make sure that we not only minimize illness, but that we're proactive, that we're accessing services to maximize health and wellness. So a couple of years ago, when this child turned 18, the mother just emailed me out of the blue. And she said that she was following up with all the doctors that had taken care of her child over the years. And I shared the quote, I want to thank you. You didn't sugarcoat what was happening and assured me you'd be there. And she told me that her daughter was preparing for college. And she said she does not let a little missing piece of the 22 chromosome get in her way. Now, I'll tell you, this made my year when I saw this. This made my year, because like when you're going through it, you're just trying to do your best, as this is, we're just trying to stay ahead of things. And I don't want to sugarcoat things, because what I've learned is that families want to hear from their physician, from their provider, what the actual truth is. So going back to 22q11, it is the most prevalent microdeletion syndrome, at least 1 in 3,000. I've seen some various estimates, but I think that's one of the better ones I found. And in 2012, the decision said no published studies are available to show the benefits or effectiveness of early treatment of mild cases or in cases without life-threatening manifestations of diagnosis early in life. There's a need for pilot studies of the proposed newborn screening test algorithm or treatment protocols to provide the data necessary to inform an evidence review. So I look at this as a practicing physician as one who, and I've taken care of numerous kids with 22q11 deletion. And my feeling is, yeah, we need to do the studies. We need the framework. We need to understand the system, and we need to understand what will happen if you maximize the system and address the focus areas and what can you do and what can we achieve for health and wellness when the system works the way it should. So I feel like this is the blueprint for children with special healthcare needs, to be able to frame system of research initiatives to make the journey more predictable and improve outcomes, health, wellness, and potential. I think that's it. Thank you.
Dennis, that was super. I'm hoping you're willing to stand up there and join in the discussion as we ask questions and continue to contribute. And with that, I'll turn first to the committee members for questions and comments. And Kyle, you're up first.
Great, thank you. That was extremely helpful talk. I really appreciate it.
Yeah.
I know this might be putting you on the spot just a little bit, but I was just wondering if you could, taking the sort of aspirational framework that you just talked about and think about where our system is currently. Do you have like a wish list of a top 3 concrete steps that could be taken to move towards a more delightful system? Like what do we?
Yeah, I don't mind. Test. If I don't talk in the microphone, they can't hear me online, correct? Test? Okay, there we go. Okay. So I actually don't mind being put in a spot. It's totally fine. The number one thing I would say is the family partners. Like, I feel like to be able to make the system designed, and I'm using the word design intentionally because there's like a whole world of design literature and principles and such. And the idea behind design is that you make the system work and you make it pleasurable and you make it delightful. And to be able to do that, you have to have all this right stakeholders at the table, and you have to be journeying together. And even now, you know, I still find work groups and cultures and organizations where there's still questions about not just whether to include the right partners at the table. In this case, I'm talking about family partners, but also to embrace and include them at all different levels. So here's, like, for example, yes, there's community advisory groups. There's specific work groups that may be at the hospital level. There's any work groups that may be happening in the community around initiatives for, like, say, early childhood. But it has to be done in a way that is partnering and not the kind of, okay, let's just have the family partners sit with a couple of chairs on the side and listen. There's got to be a certain amount of training and support and compensation for the time. And, and I think we are at a point where the literature is pointing us in that direction, that there's been more and more experiences, particularly where the family partners, like for the grants that we're putting in with my group, one of the things I'm saying is, we have moved past one family partner. You need to have at least 2 or 3, they have to be reflective. And I think that's one thing right there. Number 2 is the need for addressing, equity, diversity, equity, and inclusion. And I want to be careful about making sure that we do this with the right approaches and intent, because I find that there are a lot of organizations now that appropriately have embraced DEI, but have still not quite opened up the spaces because it can be extremely vulnerable conversation. It's got to go past conversations, right? It has to go into the areas of data. It has to go that help us, achieve from here to there. There are best practices to address diversity, equity, inclusion. There's, you look at your own makeup. Are you reflective of the conversation? Can we do blinded reviews for, when you're doing targeted recruitment? Can you expand your networks? And I think those practices need to be standard to be able to address the structural issues rather than, just simply convening a group and appointing somebody. And that's a really big issue. The third aspirational, and again, yes, the blueprint is meant to be aspirational, right? It's totally meant to be aspirational. It's totally meant to be aspirational. The other aspirational is to make sure that there's no penalty in our payment and insurance plans that put the backs on families. So I'm going to put my personal experience actually out there as a parent of a child with special healthcare needs who's now graduated college. So imagine being my daughter and hearing healthcare transition from me, right, as a dad. So, but we realized fairly early the financial penalty. And then I would go into talks where they start talking about the benefits of high deductible health plans and how it was such a benefit and a cost saving. And I'm thinking, high deductible health plans don't work when your medication costs $60,000 a year. I mean, no insurance company wants to insure me or my daughter. And so the only reason my daughter has insurance right now is because of the Affordable Care Act. And I think just mandating that we have to have this principle that when you have special healthcare needs, that you're not simply penalized financially for it. I mean, that's my other financial goal. And I think that's a challenging discussion when there is, a thought that if you have patients and families share in the buy-in, that you can control healthcare utilization. I personally don't believe that. I don't think that the research is very good in that area. And I think when you talk about families and you hear about all the families that have the financial burden, begin to think, maybe it isn't such a good idea. So those are my three.
Melissa.
Hi, Melissa Priesty, NIH, and thank you very much for that presentation. Excuse me. I have a question and a couple comments. So my first question is one that really came out of your slide where you said that the process only begins when the blood spot is taken. And I was thinking about a lot of genetic conditions, particularly recessive conditions or X-linked conditions that run in families, where you may actually know the diagnosis prior to birth and may want to prepare for the birth of that child and be ready to go with therapies that may start within the first week, 2 weeks, or first month of life. And there are quite a few conditions on the RUSP, including one that's under consideration right now, in which you really need to get that expensive therapy started, sometimes a gene therapy or a bone marrow transplant within the first few weeks of life. And I'm wondering whether this system and this new blueprint can accommodate earlier and earlier diagnosis and the need for expensive treatments that need to start so soon after birth.
Yeah, no, I very much appreciate that observation. I'm thinking I should probably change that slide slightly. There's definitely room because, of course, in Maternal Child Health Bureau's vision, it's about the health. It's focusing on mothers and children. And so that absolutely includes the maternal health. I would also push further and say that the life course is all about, throughout the entire lifespan. And that includes prenatal or in even the determinants before a child's born because of the conditions, the structural conditions that may lead towards the pregnancy and then influence the prenatal environment. One thing that I've personally been involved in, this is not related to the screening panel, but this is related to maternal child health, is let's say Down syndrome. And the American Academy of Pediatrics released updated Down syndrome guidelines. And one of the areas that we focused on when that was being developed was the prenatal diagnosis and reframing, making sure that we reframe the discussion to something that sounds straightforward, but it's not. It's congratulations on your baby, and to be able to use that as a discussion to set up the system, rather than looking at it as like, it's too bad you think about this or that. And that's where that discussion is going. Is there room in the system? Absolutely. I think it absolutely is part of it, especially since we're talking about the life course.
Thank you.
Ash.
Hello, I'm Ash Lal. I want to just support what was said earlier. I think it's the therapies currently are, we looked at them after birth, but I think the future is that many of the therapies will become prenatal and intrauterine. So that's just a comment to kind of support that idea. My question was that the mention of 85% of children with special healthcare needs are not in well-functioning programs and 15% or 14% are. I mean, in a way, it doesn't surprise me because I'm also engaged in similar clinical activities as you are. Is there something to be learned from that data? What is your view on the 15%? Are they different in terms of diagnoses? Are certain diagnoses better? The system cares for them better, or is it a regional thing, or is it rural, urban? What are your thoughts about that?
Now, that's a really good question because it is striking, but when you delve into it, there were even further differences. So the biggest drivers, so the system of services question in the National Survey of Children's Health is a composite measure, and the areas that tend to get the least positive responses are medical home and transition to adult care. So we could start there, but even from there, there are further differences. There's differences by condition, like developmental behavioral mental health disorders tend to rank lower. Children who are from immigrant families tend to be lower. Children, there's racial and ethnic disparities in these metrics. And so it's a combination of the system is fragmented and there's differences within them. And I think that reflects, I think when we talk to folks, it doesn't surprise folks, but I think that it's not a simple solution. I think that when it comes to medical home, for example, there's issues related to scope of practice for the medical home because, we're in primary care, the providers are asked to do a lot. And they're asked to do it with a financing system that does not necessarily value counseling and does not necessarily provide the resources that are necessary to be able to provide that comprehensive care to the extent that's really needed. But you also have, when areas of healthcare transition, there's learning collaboratives, there's need for awareness, and there's needs to be able to partner with the adult healthcare system so that there is a place to be able to do a warm handoff when they're going from one to the other. And then when it comes to some of the areas of, like, say, children and youth who are from immigrant families, now you're talking about a system where you have to understand the service access, the language access, the navigational aspects, and the partner with community services. So I don't think there's really an easy answer to that. We have made progress in a lot of areas. Like, you look at the insurance coverage, and the insurance coverage for children has gotten a lot better in the last 30 years, like much, much better. But I would also raise something I mentioned earlier, which is that the landscape of children's health has changed. Like a lot of our conditions that we formerly treated, that resulted in kids not surviving past childhood, the kids are living today, and the demographics have changed. So it's really a combination, understanding that if we have these metrics and we know we need to reach for it, we have to have those conversations to say, we need this many stakeholders at the table. And I do come back to the ones who understand are the ones on the ground, is the families.
On the phone, we have Janine Cody.
I thank you for that fascinating presentation. I was concerned about whether you've taken into consideration when you talk about handoff to adult care, what about training of the adult physicians who have no idea how to take care of an adult with growth hormone deficiency that's typically only been treated by pediatric endocrinologists or congenital heart disease? Or so is there a consideration not just for the handoff to adult care, but for the training the adult providers need in order to take care of the survivors?
Yeah, that's a great question. And I can tell you from being on the ground with that and being involved with some of the local initiatives that that's actually very, very, that's very high on everyone's radar. So everything from, say, congenital heart disease to rheumatologic conditions that are childhood onset to the growth hormone deficiencies, as you've mentioned. And there's even some debate about how long that these young adults will stay in a pediatric system. And yet at some point, even if you go past, say, 25, 30, then you begin to get into things that the adults, that the pediatric providers don't know. And another example, which is, again, not on the panel, but Down syndrome, as a life expectancy of individuals with Down syndrome gets longer, we're finding the same issues along with new onset conditions in adults that were not necessarily understood or seen before. I haven't seen yet any systemic initiatives to just, but on the local levels and with individual learning collaboratives, there's a lot of discussion to that. Our med-peds colleagues are particularly good at that. Our family medicine colleagues are also very good at that because there is no switch of locus of care. They continue to take care of the young adults as they go through. And these are I do think that working with family partners and thinking about the continuum of care of health and wellness, as opposed to here's a system, let's hand you off, here's a system, let's hand you off. You have to really start with the framework of what's best for the child, young adult, and family. That is when you begin to have that discussion that we need to be working together across systems.
Jennifer?
So I really appreciate Janine bringing up this very specific example, because I think I too, I think this is a beautiful framework for how we all want our children, our patients with chronic care to be cared for. I just struggle with how to, like, what I might want to do with this blueprint. Like, I think that many disease-specific advocacy groups take blueprints very similar to this, or have ideas similar to this, or could use this blueprint as a way of creating standards of care, or guidelines of care that they hope providers for their patients will, for these children will adhere to. But I was curious how, so I'm already sort of formulating ways to try to think about this without being consumed by the fact that the deficiencies that are highlighted by this aspirational document are so numerous, right? They're just they're overwhelming. To think of a system, a financial system, for example, that really gives children with chronic disease or disabilities the care they need seems really pie in the sky. And that's just a small part of what you're talking about. So I was curious how you see this document being used.
Yeah, no, thanks. That's it can seem daunting, and I think that when we put the blueprint together, we were asked to be aspirational, knowing that we weren't going to come up with all the solutions from the very beginning. I will contribute a few thoughts. The first is that there have been numerous examples of policy and financial initiatives that we know help and do work. And when we talk about the system, we have to support nutrition, we have to support coverage, and we have made substantial advances in that understanding in the programs over the last several decades. I go back to when I was in medical school and I look at the insurance rate coverage for children, and I look at it today, and I look at the changes in Medicaid, and it's huge. Another area I would advocate, so we have to look at those policies to be able to strengthen just this, just the supports for kids' well-being, coverage, food security, and access to care. That's one. Another area where I advocate is that we're really pushing folks to think in a way that's holistic and systems-based, because as a physician, I came through a medical training system where I'll go back to my own training, where it was, okay, if you see a red eardrum, and at those days it wasn't even, it had to be red, bulging, and pus filled. It was, if you see a red eardrum, give the kid 10 days of amoxicillin. And then somewhere along the line, I also realized that, well, these kids are coming back to me and they weren't necessarily taking the medication for all sorts of reasons. And I think that training and that the understanding of how to think differently holistically involves several things. Once we have the principles that we have to think this way, it involves the stakeholders that you bring to the table. It involves the questions that are asked. It involves imagining in ways that we don't necessarily know or understand. I will come back to, I give the Down syndrome example because for me personally, that was quite impactful in that I had numerous partners for me, family partners who work in the, who have kids with Down syndrome, who are very, very specific about that. And to see that in the, that the prenatal discussion was, to see it in writing, what I'm told was, it was incredibly well received by the colleagues I have in the Down syndrome community. And that started because we allowed ourselves to come to the table and have these discussions with the principles that families and communities are at the center, and it's about the health and wellness of the child and the family. And I think these little discussions, little by little, that's just one example. But these discussions little by little start to make that difference. I think we were asked to put the blueprint together with like a 15-year time window, say this is where we need to go. But I do think that there are steps and strategies, and some of those principles, they don't come necessarily from the healthcare field. I mean, to think of a delightful experience, I've never heard that in healthcare training, but that is what the IT sector is using, and I think we should draw on those lessons.
Shanika.
Shanika Ponpatkun, committee member. Thank you very much for your talk. What struck me was the transition of care, which seems like sort of, we've been able to keep our children alive and healthy and transitioning them out. I think Down syndrome is a great example of the natural history that continues to evolve. And I am interested in hearing your thoughts about, how can we help children who has, specific medical diagnosis, which I think the pathway is actually it's actually more straightforward, like asthma, diabetes, while children with intellectual disability, chromosome disorders, Down syndrome being one, but all the microdeletion syndromes, and how can we help them, the family, get to that point, not just working with the primary care, but all the subspecialty that may be involved in taking care of these adults in the future. Thank you.
Yeah, no, thank you for highlighting. So we're talking about specifically our children and youth with intellectual and developmental disabilities and the systems that the children and their families reside in, which I purposely highlighted the part in the definition of children with special healthcare needs that it does include the group with intellectual and developmental disabilities, so kids with autism, for example, the kids with genetic syndrome diagnoses that also are associated with intellectual and developmental disabilities. It's a complex system, and I think the pandemic in particular highlighted that if one system falls apart, like we close the schools to in-person learning, it just has the cascading effects in so many other areas. I know of initiatives, and one initiative, I'll just give one example, is in New York State, we have the First 1,000 Days initiative, which purposely strategically brought together the education and the health sectors to be able to have those conversations so we know those kids are going back and forth through them. There's also, to give another example, when we're looking at the child and family as a center and framing this as a just and fair opportunity. So this actually is framed in a civil rights framework that you begin to get into aspects of guardianship and supported decision-making and some of the research, which is still fairly new, but it shows that if you empower and you recognize the inherent rights of the child and the young adult, that the healthcare outcomes and the functioning outcomes, the educational outcomes as a whole just tend to be better. And I think that starting a big part of what we're doing is framing this as it is equity, it is fairness, it is potential, it is recognizing and affirming the rights of the child and the family. And when you start with that framework and you start with discussion at framework, and there is some literature in that area and it continues to grow, then that sparks the right conversations. With regards to intellectual and developmental disabilities, navigation is a huge issue. And I continue to do this in my own personal practice. Navigation, especially going between not just the school and the medical system, but like within the medical system, between the hospital and mental health and developmental behavior pediatrics, that's an issue. And so we're down to things like recognizing that the journey and the navigation is the issue, is one of the primary issues. Like when they tell us that care coordination, that a lot of our families are telling us that they're not receiving care in a well-coordinated system, then the conversation goes to, we need to provide care coordination, but we also need to recognize it's not enough to just say, here's your care coordinator. They need to be versed in the right system. They need to be versed in the journey. They need to be versed in empathy. They need to be versed in cultural humility and responsiveness. And you build those relationships. and then you see how you're doing, and you use those metrics of did you achieve family health and wellness. So I think the blueprint does frame the discussion by saying it's about experience, it's about lived experience, it's about equity, it's about being just and fair. And if we take that as a starting foundational point, it'll lead to those questions of things like navigation, shared decision-making, training, and allocation of resources to legal questions such as supported decision-making and guardianship. It's a complex issue, but that's the way I see it framing. You've got to start with the areas of equity and fairness.
Dennis, this is Ned Kalonge, committee member, and I was thinking kind of along the lines of Jennifer. So I know you say it's aspirational. I also know you want it to be impactful and not just aspirational.
Absolutely.
So I do find myself thinking about the diverse stakeholders and the diverse fabric of resources that come into play, and think about what are your plans for dissemination? So understanding that you need to impact MCH and MCH block grants and funding and special needs programs, CDC from EPI, HRQ from systems research, NIH from effective interventions. And then Medicaid is a shared program with states. So state legislators and state Medicaid programs and public health. So, and then providers, so pediatricians, family physicians, and subspecialists. So what are the dissemination ideas, and how do you see the blueprint starting to impact those resource centers to come together to provide actually funding that flows towards supporting the implementation of the blueprint?
Yeah. Because the blueprint's in print now, it's really just the beginning of saying, we have a product here that we can refer to. And when we release a fairly large product like that, it also catalyzes everything from our social media messaging to our talks, to our presentations, to the decisions that go into policies, to the decisions that are going to funding opportunities. I will speak as an individual and not on behalf of MCHB on this, but I have been in conversation with partners at MCHB about how we're working together in all of this. Talks and grand rounds, writings, publications, interviews, podcasts, those have started to all go out. Grant funding opportunities, programs, policies, that started to go out. In New York State, because in my day job, at Rochester, we have funding, we have funded projects through the state, and the blueprint is being looked at the Department of Health and saying, we need to move away from, here, plug your, like refer to here, refer to here, refer to here, to how can we walk through this journey together? That's a big change, but because we have the blueprints, we can point toward this and say, this is how we want you to think. Now, the interesting part in my personal experience is that when I talk with my colleagues who are on the ground, who are right now still, in some cases, feeling very frustrated in their position because they just think that they're trying to plug holes and do this. The blueprint is a game changer because it points to a framework that we need to reset that discussion. So yeah, it's little by little, but we definitely asked that question, and that's where we're going.
I appreciate the answer. Michael Warren wanted to make a comment.
Sure. Thank you so much, Dr. Kuo. Thank you, first of all, for that amazing presentation and for your leadership throughout the development of the blueprint. The Bureau really appreciates your partnership here. I wanted to touch on a couple of things that relate to this notion of dissemination. So one is we're in the process of updating the MCH block grant guidance that guides the work of the state Title V programs in the 59 states and jurisdictions. That happens every 3 years. And so we're incorporating the work of the blueprint there to make sure that's reflected in the children and youth with special healthcare needs works that the states will do. So that's one way that we're really going to push dissemination. We're also weaving this into our grant making opportunities that are happening in the Bureau. So we've got a children and youth with special healthcare needs research network that's looking at quality of life measures to get at this issue of quality in life and well-being. And we've also got a funding opportunity that's on the streets right now to support a national center on systems of services. This gets back to this issue that Dr. Kuo talked about generally we haven't met the mark for children being cared for in a well-functioning system. And so the principles from the blueprint are reflected in that NOFO as well. So I'm trying to put our money where our mouth is here.
Dr. Ward, thank you. Thank you for your vision and leadership. And yeah, from the ground, I definitely see those changes. But I'm also very, very glad that you were able to be specific on behalf of the Bureau.
Yes, Michael, I'll echo. That was the right answer. I appreciate it. If I could turn to our organizational reps for comment or questions, starting with Natasha.
Hi, Natasha Bonham, Genetic Alliance. First and foremost, thank you for such a great presentation. I know many people have said that. I have to say I've been really excited to see the blueprint and to see all the efforts. I loved how many times you said families in your discussion. I should have kept count. And so I'm really excited. So I don't want my follow-up comments to be interpreted as though I'm not excited. I am. You know, one, you mentioned kind of this focus on DEI, which is critical, and you know how those can be really hard conversations, and people and different stakeholders can feel very vulnerable. I just want to remind us, we ask families to be vulnerable all the time, as was exhibited yesterday with them sharing their stories about both some highlights, but many times sharing the worst days of their lives. So just really thinking about that we're all coming to this with vulnerability. I appreciate what was just said about funding opportunities. And I think when you look at HRSA funding overall and SHIN funding, it's been really great to see all of the integration of family engagement in that. I'd like to kind of take a moment to look at that through the lens of newborn screening work, where I do think we can have some, this blueprint can give some guidance around that. And what I mean is that when you look at kind of the funding opportunities and initiatives broadly, they've really been focused oftentimes on lab and state program initiatives, which obviously is very important, right? I'm not trying to pretend like that isn't. That is critical. That can be the kickstart to so much. But when you see such discrepancies, like millions of dollars annually going into one slice of the system, and then maybe not even 20% of that going towards more some of the things you were talking about around family engagement, public education, like where do these stories start to link up? And that may not be a question for you, that may be more of a question for others, but I think it's really hard to constantly hear about family engagement. We want families involved and they need to be leaders and all of that. And sometimes the financial component of that still needs to be caught up. And I think that's particularly an issue when we see kind of outside of federally supported efforts more on the, what you could say, the privatization of healthcare. We really see those companies making those investments. They see where, you know, what human-centered design looks like. It goes into their marketing, it goes into their education, it looks almost opposite. And so again, though I think the blueprint, as you said, is aspirational, I'm excited because it doesn't feel completely out of touch. It feels right in line with what we've been talking about. But there are these components that, you know, we really have to line up, especially when the groups taking the brunt are the families, the very ones we say are at the center. So sorry, that was really a comment. And I hate it when people say they're going to ask a question, but give a comment. But I just think that's a really important perspective in all of this.
Yeah, first, thank you. They're honest comments, and I think they're absolutely right on. You know, I see this as all of this is a journey, and in one part acknowledging that to be a part of this conversation, to have this conversation is a large advance in and of itself. That we're here to talk about integration and collaboration, and that there are specific things and expectations such as to go back to family partnership collaboration, just the fact that we're talking about specific standards for payment and compensation representation and DEI at the center in the framework is, I'm hearing it so much more strongly than we did, say, 15 to 20 years ago. And I think those are important. Yes, we have a long way to go. And I think your comment also on, like, is the funding, is it being directed properly? Is it matched, well to where they really need to go? Those are right on. And I think that by having families at the center of that discussion, those are the questions that need to be raised when these decisions are made. I think we absolutely have a long way to go, but I am glad that we're at a point where we can have these discussions, and they are hard discussions. As I think I told my family years ago when I started to go down this path as a career, this is years and years and years. And if we don't succeed, I at least have to, we have to try.
Thanks. Robert?
Thank you, Robert Ostrander, AAFP. First of all, I am very disappointed. I didn't know you were up the road from me, because you and I should have had a conversation a long, long time ago. I'm just outside of Canandaigua. So that's really too bad. I've been working mostly with Steve Salke's in your group.
Yes.
I hate to put a pall or sort of maybe a more pessimistic spin on all this, but the way I got into this genetics world was through the children with special healthcare needs world 22 years ago, when our practice was chosen to be part of the NICHQ Learning Collaborative on Medical Home. And this is the same story, right? I mean, other than the more heavier focus on DEI, this sort of aspirational model was what we were working with. And so I don't know if there's lessons to be learned as to why that didn't take off like it should have. I'd be interested to hear your thoughts on that. Second question is, and again, I don't know how many people are familiar with that learning collaborative, but it was eye-opening because they insisted right off the bat that we have a physician, a staff member that was involved in the sort of outreach part, and a parent partner in this. And it was just terrific because it really focused all of our discussions, as you pointed out, on what's important. So one question is exactly, or do you have specific notions of how the agenda is going to be set by the parent partners? I mean, I just was on a project with the SCID group, and we did some journey mapping, which was tremendously helpful in focusing our work product. And of course, parent partners need to be on the decision-making end of that. So I think that's important. And the last two things that I want to hear about, and I think dissemination was one. One of our visions back then was that we were going to get the parents, not just the advocacy groups, but the parents themselves versed in this, so they could go to their medical homes and say, hey, we expect this from you. And that's a dissemination technique that I think, I'd like to hear your thoughts on. And then the last thing, I think one of the reasons actually this fizzled out is that the insurance companies and the government co-opted medical home horribly. We had a patient in a family-centered medical home, and now we have a payer-centered medical home, private and public payer-centered medical home. And all of our colleagues, that's what they think medical home is, and they think they're providing a medical home when it has no resemblance at all to the vision that we had during those learning collaborative years. So that was kind of a speech and kind of some questions.
This is a conversation we should have over like drinks. But I actually do have, but no, thank you. And 22 years ago, I was in private practice, and I think that we've had a lot of journeys, and so I have that perspective as well. Also been involved in a number of learning collaboratives on both ends, both internal and external. And I hear you. And I think in part the field has changed. I think that, as you pointed out, that the medical home, like if we look at the 2002 report from the American Academy of Pediatrics, and since then, it's been operationalized in many different ways, and there's been joint principle statements, and we're here and we're there. And somehow what my experience living in that world also is that the pieces are just not connecting with each other. It's like, okay, there's just a lot of check boxes that happen. And then you mentioned the financing piece, and you mentioned the partners. There's not any easy answers to it, because I think what's also changed is, like, as our care and for example in the financing world, long-term care expenses just keep going up and are straining so many of our federal state government budgets, along with the other demographic shift that we should mention is that is that the population and the share of Medicare and the dollars that are available for children's health are a smaller percentage of the pie. Let me come back to the family partners, and you had asked, what's the vision there? I think the thing that I would posit is that I'm one person, and I think that part of what we do is that as we look at our steps forward, that we are humble and responsive to when we bring the right team together under the right principles and say it's about equity and fairness and the lived experiences. Then you let that come out and you see where you go, because there are so many questions that I know answers to some of them, but then there's so many that I just haven't even thought of personally. And I think all of us can identify being in that position. One example is that when I was doing early childhood work, one thing that wasn't totally on my radar until I had two family partners part of that group is that they talked about the transition between early intervention and special education as being one of the hardest things that they had to go through. And that's not something I learned in medical school. So while acknowledging through observation and experience on there's a tremendous amount of advocacy that has to happen. And sometimes I feel like we're going, there's a bit of a 2 steps forward, 1 step back, and sometimes it's 3 steps back. I will go back to in the last 20 years, insurance coverage has changed quite a bit. And, that has given us a certain amount of tools that we have that we didn't have before. But I do think the conversation needs to lead with, and this is a game changer for what we're saying is a game changer. The conversation needs to start with the family and communities. And as you bring it in, you start to see, okay, these are the questions really, really need to be answering.
Thanks. We are over time now, but there are 2 people that have been patiently waiting in the room, and other people like Karen Downs on the phone. You can always email questions, but let me just see if we can be quick and parsimonious, starting with Margie.
Margie Ream, Child Neurology Society. I was wondering your thoughts on how children who are identified at risk of newborn screening conditions that may be late onset, they don't have the benefit of a specific diagnosis that may gain them access to care, but how do those children at risk but otherwise healthy fit into the system? And also, I guess maybe more of a comment that the idea of family-centeredness, when we talk about diagnosing a heritable disorder, is a family diagnosis. And is there a way that family-centeredness could facilitate access to care for mothers that may be carriers for X-linked conditions or other family members that may need to be screened now that we have the child identified?
Yeah, thank you. Very brief answer is medical home, continuous screening, surveillance, but also making sure that there's team-based care. And it has to look different because, and it'll look different in different places because, it'll look different in a solo practice versus a group practice versus a hospital-based practice. But when a system is there to not only identify, but also to be able to screen continuously and collaborate with the schools, that's how, the system is designed to be able to work, to be able to catch those issues. But I think the other thing is, under the life course and under, like say the Bright Futures guidelines from these, we have to talk about developmental promotion and health promotion. And there's probably more and more work that really needs to be done to think about how do we promote the kids at risk? Because I think that you've got to be much more intentional with those kids. Yeah.
Siobhan, you have the last question, and Karen will get yours email, I hope.
Thank you so much, Siobhan Dolan. I am going to make my comment just as an obstetrician and geneticist, so not really an organizational comment, if I may, which is I appreciate all the conversation today, and
absolutely support the idea that we have to be thinking about transition from childhood to adulthood and managing these conditions. But I'd also recommend and bring up that when we think about fragmentation and we think about patient experience, everything that's gone on prenatally, and I admit that's my lens, but it's enormous, and there's enormous pressure in there. There's a lot of industry investment in diagnostic testing. It all sort of escalates to 20 weeks, and then it's like, okay, just tread water, hold on, we'll get back to you at newborn screening. And actually there's an enormous window there. There's lack of data, right? Actually, medical records have worsened the situation of data because the mother's record with all the prenatal diagnostic testing sits here, may not get to the baby's newborn record if you have an electronic system, and most certainly won't get out to their community physician. So I just want to ask, just sort of comment and bring this perspective to this committee, that the sort of fragmentation, which is at largely the heart of a lot of inequities in our health system, are already being deeply exaggerated by what we aren't doing. And I say we very generally as a healthcare system between prenatal and newborn, and actually also harnessing the data that's collected in that period. So that would be a question I would have as I close here with the blueprint. Could that be used as a sort of framework for data collection? Because again, there's going to be investment in the prenatal area around gene therapy and around treatment and outcomes. And could the blueprint be put forward to say, look, this is what you collect according to, so we would have good data and not just one-off treatments that we really can't learn from as a system.
Thank you. I have two quick comments to that. One is I absolutely agree about the data, and having been in different healthcare systems with different data and EHR systems of varying qualities, it's huge. And I don't think that we've realized the potential, but the potential requires a certain amount of investments that, and also, frankly, things like human-centered design interfaces and thinking to make it actually useful, as opposed to like, okay, just click a box here and you'll get paid more for by saying that's what's going on. The other thing I'd come back to is actually relationships. So when I was in private practice, we routinely visited our OB colleagues, and I assumed that my practice that I started out with still does that, because we would have that interface, because that really did make a difference in that after that 20 week where we could have that conversation. And overseeing the newborn group in one of my previous positions, we started to do the same thing. And it was just interesting that we just started to reopen that window. And I would advocate that, we're all part of a system. And if we center it on the journey of the parent from prenatal all the way through adulthood and then back to prenatal, then we see that we're all part of that continuum. And sometimes it's just a matter of getting out of our offices or screens and going and say, let's just chat and see how we can work together.
Well, Dennis, clearly you captured our attention and interest and did a wonderful job. I hope everyone will join me in thanking you for a great.
Thank you very much.
And Kyle, I wonder if you'll come up and get us started on our next agenda item. You'll remember that we asked the work groups to think about their last meetings and the solutions they identified, and hopefully come back to us with some priorities that the committee might have a hand in pushing forward.
Great.
We're going to start with follow-up and treatment.
Great. Thank you so much. We have a really great group. We had a very active conversation yesterday, and I feel like we're sort of, making headway. So go ahead to the next slide, if you don't mind. We last time we met, we kind of brainstormed like what are some ideas that might help us move along the implementation of new conditions at the state level from the perspective of follow-up and treatment. And I must say that just making that connection took a little bit of work to think about follow-up apart from the bigger picture of this whole spectrum of care, continuum of care, and focusing in on what are the pieces of the follow-up and treatment pie that really affect how states implement new conditions when they're added to the RUS. So these were sort of the three big ideas that we came up with last time. And then this time we tried to focus in on which of these do we think is the most important, the most practical, the one that we really want to focus on. and what are the concrete steps we could take towards making that a reality. So go ahead to the next slide. Great. So we really reached consensus yesterday on the idea that we'd like to request a blueprint, which ties in nicely with a nice talk, for follow-up and treatment as a part of the RUSP nomination. And one of the points that the committee made repeatedly was that this is not just a task for nominators, it's also a task for the committee, both to give guidance to nominators about what it is that we're looking for here, but also for the committee to utilize that information to hopefully get it out to the states to provide guidance on this is the follow-up strategy that you need to look at in order to get this this particular condition out and ready to go. So we really settled in on that piece of the nomination, but with a element for the committee to really consider. Okay, next slide. Okay, so what does this mean to have a blueprint for follow-up as a part of the nomination committee? I just want to say we got to this piece of our discussion very late in our time. So this was really more sort of a brainstorming, throwing out ideas conversation. And so I really want to highlight this is preliminary. I think this is sort of like the straw man that will start our next conversation about what do we really need to focus in on in this idea. So I think this is kind of what the committee came to yesterday. Basically, the blueprint that the nominators would include in the nomination for a new condition that hopefully the committee would then leverage for guidance would include a breakdown of the subgroups of screened individuals who will be identified by newborn screening. This is different for every condition, as you all know. There's pseudodeficiencies. There are patients who are asymptomatic early in life, but then later become symptomatic. For certain conditions, we're actually screening for markers for a condition that some children already have symptoms at birth. So there's really a broad spectrum of different kinds of subgroups that we might need to worry about here. But by breaking it down, that really helps to get the states moving on thinking about what are the different follow-up pieces that are needed for these different subgroups. And then, we would want to identify those groups, however, that is specific to that condition. So symptomatic versus asymptomatic, what, maybe the various levels of relevant biomarkers, as we discussed yesterday with cyclozine and Krabbe disease. And they're different for every condition. Go on to the next slide, please. Okay, so for each subgroup, we would be asking the nominators to propose standardized terminology. This is really key, both in implementation and communication about implementation, but also as a starting point for gathering data in the follow-up stage for the different groups. What are the outcomes that we're observing in terms of short-term follow-up, and then maybe, eventually long-term follow-up. And then we would be looking for guidance on the follow-up needs specific to each subgroup. So which professionals would be needed, which types of evaluations, laboratory exams, radiography, et cetera. Where are those located? So for some of these conditions, as you all know, the short-term follow-up plan pieces of that might be specific to regional centers that are not available in every state. There may only, for certain conditions, may only be a few centers in the whole country. So really important to be aware of that. And then what are the resources that the state would want to sort of check off as they're working on getting a condition implemented? What are those resources that they sort of need to identify and figure out, okay, do we have access to this? How would our families get access to these resources? Next slide. Okay, then the blueprint would focus on the follow-up needed to identify whether a screened individual has the newborn screening primary condition. So we're not really talking about the follow-up needed in the long term about if a patient who's asymptomatic at birth but identified to be at risk for a condition does get follow-up treatment, what are the long-term outcomes, right? That's That's sort of a different question. And although the states care about this question, it's not really within their purview in the short term when they're implementing a condition. They're really being asked this initial process, which for some children is days, for some children is years, depending on the condition, to identify, does this child have the condition that we're screening for? And once the state is aware of whether or not that child meets those criteria, then that's moving into a different system of evaluation and care. And yeah, the reason that we really wanted to focus in on this particular issue about identifying which of these children actually have the condition being screened for is that this is really the component that for the states when they're implementing a new condition, that's the top priority in thinking about what follow-up pieces they need to have in place. I think that might be it. Next slide. Yeah, okay. Yeah, are we doing questions now or?
I think what I'd like to do in the interest of time, because we have like a full hour, I think, to try to do discussion, is ask people to write down their thoughts and questions as we go along, and then we'll have a break and you can solidify those. But that was great. Thanks, Scott. I'd like to have Kelly come up to the podium for laboratory.
All right. We had it was great to see everybody yesterday. We had a fantastic session. And I think ours is a little bit more immature than what Kyle provided, but we can give you some of the, brainstorming that we took from the last meeting and at least tried to whittle it down to things to put out there in terms of some possibilities. And next slide. Where do I do it? Anyway, the group, we had almost everybody participate, which was great. Next slide. And next slide. So the brainstormed list that we had of ideas from the last meeting, most of them fell into two flavors of things, and then we had some other outliers. One of the things that we heard from the programs was a lot of ideas on how to help program development around a new condition, things that people had seen help them succeed or where they found challenges, and that we could help by giving some attention to program development. And I would say most of those things are sort of where we felt that our work group could help give a lot of help. The other flavor of things was, for example, improvement in technology. We had talked about things like other specimen types or, improving sensitivity and things like that. And while I think that would be, still something that needs a lot of attention, I'm not sure, our work group could obviously hear about that from partners, but obviously was a little bit out of our wheelhouse. So the things that we heard from the programs that we could in some ways build on things that are already there, and again, I guess more centralize it as a product that the committee could help with, is both what we call a quick start guide and a project plan worksheet for implementation of a condition added to the RUSP. So when the public health assessment of a potential condition is being completed by APHL as part of evidence review, they're already putting together what they call a fact sheet. One of the things that we heard was that there actually, could be expansion of that to add additional information that would be helpful, because those fact sheets, for example, could then be, and the expansion of the information, there is APHL and New Steps takes that, and that when a condition actually is added to the RUSP, there is a toolkit that is developed for states to use. And one of the comments that we heard was, well, it's like a 39-page report. And when I want to give it to, for example, my advisory board, it's too much. And so a shorter quick start guide, which we would build off that public health assessment fact sheet with a little bit more detail, would be really helpful, is what we heard. So that's the first thing. So there already are some resources, but we heard that, where perhaps the committee could help was looking at that and seeing where there could be expansion or more detail added that the state programs think would be helpful. The other thing that had been brought up was that states found that having a champion or project manager when they were starting from something added to the RUSP to screening in their program was really helpful to drive getting all the pieces together. So some states have started looking into having that type of project manager or champion, but some states don't really have that resource. Is there some way that the committee could have what we considered a project plan, sort of a shell or a worksheet that would include, what, these states that have a project manager might, have from, when you've got to sit down and think from, day one, and then check the boxes. And the idea would be that this obviously, a state, we would have to consider that states have different ways that things are done, different groups, boards, legislation, as we talked about yesterday, the states have different steps that they have to go through. It's not all one size fits all. But the idea would be to have that all in the shell and that states would obviously use it and format it to what their program needs. But then, would include obviously, if you actually have to bring in build up a new, room, equipment, FTE, there would be this part of the shell. You would start and you would go in that direction. But if you're building off an, method that you already have, then you would go here. So it would basically be a project manager worksheet that states could hopefully use and build off of that tool if that's something they don't already have. So they're different. So one of them is more about the content of what we look at in terms of reviewing the RUSP, and the other one then is actually the implementation. But states said that they really need both when they're going to implement something added to the RUSP. The other thing that that we've obviously heard a lot of discussion about in general at this committee or even in our work group over time is, second tier testing, and a lot of sharing of information about second tier testing. And we know that, different ways that states consider these things. And we know, there's been a lot of discussion about regionalization and specialized testing, et cetera. We really, it doesn't necessarily just apply to new conditions. Obviously, we've had a lot of discussion about improving things that are already on the RUSP, where we know about people developing second tier testing or using that to improve. So although this is, we thought about this in terms of implement, new conditions on the RUSP, it wouldn't be limited to that at all. But again, this is a document that's not for a specific condition or specific test, but would be a best practices document for states to use when considering the utilization or addition of second tier testing, including regionalization. So, and as I said, it could be prospective or retrospective. And what we heard was that this would be really helpful for states to be able to use both to, to assess their current performance and think about how they can improve what they're screening now, how they could do better. And then it would be aspirational. They could take it and hopefully use this when they're telling people why they need a second tier test and show them and use this resource in order to do that. So, and there's a lot of interesting discussion. I think, we heard a lot that CDC does a lot of work in general on looking and assessing second tier testing in their lab. I mean, all those things I think we can pull from, a lot of our partners in putting together this type of best practices document. And the last thing is a little bit, we got a little off, had a passionate conversation that's a little off the the chair's assignment. So I apologize in advance. Although this is something that has come up in the past from advocates about the whether or not we're doing an effective job of screening for homocystinuria. But I wanted to put it here just because it was another place where we had a real, interesting discussion from several partners. And whether it doesn't fit in this, I also think it's something that we'll be hearing about in the future and maybe something of interest to the committee, sort of like our work in the past on succinyl acetone. But we know that current methodology for screening for homocystinuria is not effective, and that there is a false negative rate that is, that we heard from the advocates is a problem. And we've heard that CDC has been working on this, and I think we're interested in the potential of gathering that information and seeing whether or not it is something to bring to the committee, something to come back with that may or may not be similar to the succinyl acetone story. But we figured that was number 3, but is not really part of the assignment. So we apologize, but we wanted to bring it forward. So anyway, that's it. Thank you.
Thanks, Kelly. And Jane is making her way, and you're up last, but not least.
Hi, that's a tall order there. Okay, thank you. Next slide, please. Our work group, education and training, met yesterday, and we had several lively discussions. Next slide. It'll work. Okay. I just wanted to thank the committee for all their input yesterday and how we worked on our different questions. So we were charged with 3 top priority solutions the committee can consider on acting to support state implementation of conditions added to the RUSP. So this was the outcome of our last meeting in terms of these different solutions that were generated by the work group. So we came up with a little bit more than 3, but some of them actually folded on each other, particularly around developing goals for education and training and considering basic genetic and newborn screening education. Some of the things that we thought were probably not feasible, although were really important, was developing evaluation methods for measurement. So that is still sort of in our catchment, if you will. So we discussed support of existing good training and materials, assuring diversity and culturally tailored materials available for the families, partnering with governmental agencies working in similar spaces, task force, for example, and then again, something that's more germane to education and training, developing those goals and considering basic genetic and newborn screening education. So a rich discussion ensued. Okay, so what is the focus? We spent some time talking about who is the education for and who's being trained. So education and training needs are different for different categories of people, and we already have a really good document that was created several years ago in terms of educational planning guide. So what that consists of is it consists of all the stakeholders and then these different topics that will run across the top of this matrix. And we can see how some of these topics are important to different types of stakeholders. So we have patients, clinicians, the public, and more. So patients really are the priority, but education needs to exist throughout the system. So if you look at the matrix, we have 31 distinct audiences or stakeholders, if you will. And then we know we have 28 distinct topics. So we're lucky. We've got to jump on that because we have this existing document. So how, where is the information or training located? There's a lot of existing educational materials and training centers, if you will, that already exist. So I think that what it boils down to is how can we gather this in a way that this could be utilized? Is there like a central way that we can deposit this, or a repository, if you will? And there are centralized resources already that we can look to. So we spent some time talking about how we might be able to do this so that people can get to this great stuff. Gathering, organizing, creating, use of templates, these existing places for education materials, and then that money has been spent on really good training programs. Let's access that. Let's use that. So the core question for us, and I think it's for other work groups as well, are we speaking about the newest disorders, or do we want to go back to some of the older conditions where education is still needed? So, and then we talked about websites are good, but there's even more ways to reach out to people in terms of getting messages across in terms of social media. So screening is getting bigger, and not just newborn screening. This was a really important discussion we had about prenatal screening. Yes, we are newborn screening, but prenatal screening is getting bigger. There's more tests. There's a huge influential industry there, and there's often misunderstanding on the part of providers as well as patients who utilize those systems. So oftentimes you don't get to newborn screening without passing through prenatal screening. So parents can come to us already understanding or misunderstanding aspects of screening that could be really important, and they carry that into our area. So is more screening better? That's something we ask all the time, is that the number of tests that are screened for, does that really make a better system? Not always. And we don't speak consistently about these concerns. And it was brought up that the New York Times ran a really important article in the beginning of the year in January about the uses of prenatal screening and how it's really quite concerning to families that get caught up in this. There's information that's put out there, it's not interpretable. And then in the spring, the FDA actually had issued an advisory in terms of using prenatal tests. So there's potential for more confusion, not less, and maybe we want to think about prenatal screening in the context of newborn screening. So to come to our issue of partnering with government agencies, we can identify strategies to partner with these different departments and agencies, because we may have things in common and there's potential collaborations that we can engage in. There was an article published this year in terms of newborn screening research sponsored by the NIH, and there was a wonderful diagram, the road to the RUSP, which showed the sort of interlocking of different governmental agencies and how they all are contributing to when particular disorders get placed on the RUSP. So we thought that this might be something that we could utilize. Federal agencies have different missions, so we want to be able to identify people and approach them when we're ready to talk about doing a collaborative effort. Now, the other thing that came of this was also connecting with professional organizations, because they're a great resource in terms of getting information out. They have educational endeavors that they're engaged in, so it's not just government. We can be talking about organizations like the ACMG, ISONG, et cetera, APHL. So we are prioritizing culturally appropriate information, education, training. This is very, very important to our group. We live in a diverse culture that's becoming extremely more diverse. So do we have appropriate materials that are culturally appropriate, or can we create materials beyond just using language? But how can we create materials that have the look and feel for something that's culturally appropriate for different groups? Newborn screening programs may differentially affect people from diverse cultures, and we need to understand people's experiences of healthcare, because when you come from another culture, you may see healthcare in a very different way than the dominant culture sees it. And we need to understand people's experiences so that we can address inequities as well. Education and training is everyone's responsibility. We are the work group, but it is everyone's responsibility along the continuum of newborn screening. It's the responsibility of every stakeholder. Everyone needs to continue learning and building their skills. We can find out what is being done and what exists to be able to create a blueprint for us in terms of education and training. So our three top priority solutions that we considered actually has come about as a statement. So priority focus in our solutions, it's partnering with governmental agencies and professional groups working in similar spaces. We will support development, distribution, and awareness of diverse and culturally focused new and existing newborn screening education programs and materials, ensuring the coverage of basic genetics and newborn screening for all. So hopefully that'll be something that we can engage with the committee. And that's it.
Wow, those were three fantastic summary presentations and a lot to think about. And I would like to challenge folks to think about questions and the discussion, which will start around noon in about 25 minutes or so. We will spend the rest of the meeting kind of talking through these and thinking about how they might translate to action items for the committees, the committee, the work groups, and others. That's going to kind of take us to the end of the day. So I'll see you back kind of in your seats in about 25 minutes or so. Thanks. Oh, the miracle of the Friday afternoon meeting in DC. So I appreciate those of you who are able to stick with us through the end of the meeting. And I hope as people start making their way to respective airports and metro stations that your travels are safe going forward. So we're going to try to reconvene and kind of finish up today with what I know will be a lively discussion on advancing newborn screening systems. And I would like to start with just specific committee and organizational representative questions about and comments about the three presentations. And so if you remember, we started with Kyle and your three issues were you had them.
Yeah, our three starting points. One was having the committee, when it does recommend adding a condition, to also recommend a follow-up plan. The second one was asking professional societies to put out guidance specific to the newborn screening context for how to follow up and treat the various subcategories of conditions. And then the third was asking nominators to lay out a follow-up blueprint. And so we focus on the third, but hopefully the third would inform the committee being able to put out a follow-up plan when it recommended adding a disease to the breast.
So let me start with committee members and questions or comments or suggestions for this specific issue. Mark Williams. I'm sorry. Mark, if you'll wait until we get through the committee, which will take another 10 seconds. Jane, thank you.
Kyle, thank you for your presentation. So my question is, this blueprint, because the states are so different, is a blueprint going to look different from state to state? I like the idea of a blueprint, though.
Yeah, I think the idea that I'm speaking on behalf of others here, so I might get this wrong, but my understanding of the blueprint is the features of the condition and what follow-up is required for the different subgroups, which would not necessarily be specific to a state's infrastructure, but would really be more about the disease. And then the states have the task of filling in the blanks about how would we manage, or how would we offer follow-up for this subcategory. So just thinking about, a condition that requires ongoing hearing screening for the first couple of years of life. How are we going to make that particular kind of resource available to the patients?
And I just had a follow-up comment. So in the process of a disorder who's being evaluated for the RUS, how early would your group want to be in there? Would you want to be in that earlier piece where you could see how people are talking about different disorders, what the expectation is? Or because it sounds like if something is approved, then you're coming in, you know what I mean, almost behind or after the fact.
Yeah, the idea is that that would actually be part of the nomination package. So we would ask the community of folks who are putting in the nomination package to really lay out, what are the subgroups here and what's the follow-up plan for the different subgroups as part of the nomination package, which actually I think is kind of a brilliant move that the committee is making there, because I think it is sometimes difficult in nomination packages to really sort out who are the subgroups here and who are the groups that are being proposed to benefit from newborn screening. So I think even that task alone is probably valuable for the overall question of how we, sort of process and think through those nominations, but also would be a valuable resource then for the states afterwards.
Melissa?
Melissa Parisi, NIH. So as you were describing this, Kyle, I kept thinking about natural history, which I don't think you use that term specifically, but so many of these conditions, we have limited information about the natural history. And that includes information about the penetrance of having a given condition and the variability in the expression of a given condition. And so my hope, I guess, is that if such a blueprint for follow-up could be developed, that the data that would be gathered from following these individuals longitudinally could help inform our understanding of these conditions. And in some ways that is sort of blurs the line between research and practice. But I think that, our goal and our hope, certainly with the Newborn Screening Translational Research Network and some of our follow-up activities and our longitudinal data collection, is that there would be a mechanism whereby we could learn from babies who have these conditions so that we would understand the natural history so much better in the long term.
Yeah, I think you're exactly right. I think we need that information desperately. I think one of the key questions here is about when we transition. The terms long-term follow-up and short-term follow-up are frequently used. I think we need to be more specific than that, because I think the states, when they're implementing new conditions, it's really within their purview, and they really need to worry about the initial part of that natural history about individual has screened positive. At what point do we know whether they have that condition or not? Really, we kind of use the term short term. In some cases, that's not very short. That actually takes weeks to months to years. So I think that's sort of within the state's area of responsibility to understand, are we coming up with false positives? What about false negatives? Is this process working? Then the issues you're raising, which are really longer term, that's sort of like, okay, we know this child now has this condition. What happens in the process after that? What is the outcome of treatment for children who are just being followed without treatment? What's the natural history of that course? I think that we could sort of use the broad term of long-term follow-up, and that's a space that we are not necessarily putting into this recommendation for what we should do next. But I think we do need to be thinking about how we interdigitate those two things, because it really is critically important that we understand that long-term piece. It just may not be within the state's purview in the implementation process. So yeah, I think it would be wonderful if we could figure out a way to really make one lead into the other successfully. And I'm just not going to hide this message. I think the NIH can play a critical role in that particular stage.
Sean?
Thanks, Kyle. Two questions. Who is the target audience for the blueprint is the first question. And the second one is, how is this different from developing guidelines for management and treatment of diseases? And if it is the nominating group really the right group to take that on? Or are you proposing that we ask that there be some sort of consensus treatment published prior to a nomination being submitted? I'm not sure where we're going with this.
I'll tell you what I think, but I also believe this is probably still a point of discussion that the group needs to have, and we would welcome feedback from the broader community. I don't think we're focused on treatment in that way. I don't think we're focused on, we now know this child has a condition, what's the treatment plan and how does that follow? I think we're really, what we're focused on ends at that point. It's the states need to figure out, can we get the child identified to have a condition and in contact with the services that they need in order to get appropriate treatment. After that, that moves out of the state's purview into sort of the healthcare system writ large, right? So I don't think we're focused on that piece. We did have quite a bit of discussion in it, and I do think there's still an open question about, do we need sort of clinical practice guidelines in order to inform that initial step? Because, you know, you could imagine a group like ACMG having treatment guidelines for children with PKU. That doesn't mean they're actually providing guidance for what happens when a child screens positive for PKU. Those are two different things, right? And in some of the conditions we've been considering recently, there's a huge difference between the people who screen positive and the people who actually have a condition. And so I do think there's room for working with those societies to really give us that guidance on the first step. This is not a guidance for treating a disease, it's guidance for a positive state on a newborn screen. But I do think if we are going to add a condition to the RUSP, it's extremely helpful to understand what are the different situations that will arise through that. That's just helpful to us in making the decision. And sometimes it's hard to identify that in the nomination package. So I think it's critical. So I think it is very useful for that. And then the second target, and really the primary target, is that if a condition does actually get added, that there is a starting point for the states in understanding who are the different groups that we need to think about, what's the standard terminology we're going to use, so that when we are working together to report that, we are using the same terms and we know what their definition is. And then hopefully have the states be able to quickly identify what are the resources they're going to need to bring to bear to make sure that the newborn screening process is getting started, you know, correctly.
And would that include providing then case definitions to the states rather than the current system where every state figures out for themselves how to define a case?
I think that's critical, yes.
Yeah, Sean, I think it really is. I would say a responsibility of the committee in making a recommendation of an addition that, I mean, I think we talk about this a lot in the back and forth on nomination packages. So what is a case? And so it's not what is a positive test, that's another issue, but then what's a case? So it came up with Crabbe about, you know, those 9 high-risk kids in New York and only 5 had the condition. So what was the condition that was actually specified and what were the other 4? I think those are really important things to really have. And I've seen you do this in your reviews to zone in on commenting about what are we talking about, what's the condition, and that's a nomination issue. Recognize that the committee needs to do its work, and the evidence review group has to do its work based on the clearest and most specific definition of the condition we're trying to find and treat possible. So it's like a key part. Yeah, Kyle?
I think this ties in with your comment yesterday about the secondary conditions, because I think we don't just need a case definition for the specific condition where we think there is a benefit from newborn screening. We actually need separate case definitions and standardized terminology for each of the sub situations that occur when a patient screens positive. So You know, what do we call these children who are born symptomatic and are screened positive? That's a sort of its own thing. What about children who have, you know, this particular biomarker is low, so there's a question about whether that might be a pseudodeficiency or whatever. We really need those to be broken down and named in a very specific way. The states need that, and we need that in assessing the nomination, not just the what is, for example, what do we mean by when we say Krabbe disease? It's actually the whole set of the different situations that turn up when we start screening.
Right, and I guess the only thing that you know, a small group has talked about during the break is it could be that a lot of the information that you're talking about would come out of the evidence review group because they talk a lot about treatment. And so thinking about those issues, and that might be an additional source of filling in that blueprint for short-term, and I'm going to say it, not long-term treatment. So whatever that is, right, there's diagnosis, and then what do you need to do in 30 days, for example, for rapid treatment. And then I think we do need to have a good sense of where do you get that. So that was so important in SCID to say, okay, we identify all these kids. Are there enough centers that do transplants and routes of transportation and coordination of care to make sure that once we identify you, you actually get the therapy that will save your life. So I think those are important things to keep in mind. That could be part of the blueprint. Jennifer, you put your card back down, so, but
I'm going to just make a very quick comment. I think that one of the things that came up yesterday is that we do want to help states implement these programs, but I also feel like we put these imaginary boundaries about what is the state's purview and how do we negotiate between what different states want versus what, and I guess I want to go back to this this idea that Dr. Ko brought up, which is we're here to take care of a child identified with a serious and chronic disorder. And when we talk about short-term guidelines, long-term guidelines, all of these other issues of implementation, we really need to keep all of these things in mind. And the fact that we're worrying about if it's going to interfere with implementation, I think raises a bigger concern about what we think of with newborn screening and what we think we're trying to do in newborn screening. I think that we're all here to take care of the child overall, and we do want to implement these new disorders. And in order to do that, we have to integrate long-term considerations into our conversations about implementation.
thank you. All right, I'm going to turn to our organizational reps, starting with Jerry.
I think Kyle ought to really be congratulated for handling this very difficult problem discussion yesterday. When I first saw what the charge might be, in other words, what we should focus on in those three things, it struck me that they really all ought to be implemented right away. And in other words, we have the American College of Medical Genetics. They've had experts in the field that have looked at certain diseases. I don't see why that can't be in place for the committee at the time when the recommendation is being made, and not as something that would happen at a later point. And one of the things that struck me, and this is the main thing I wanted to go to discuss, is it seemed like there was short shrift that was really being given to long-term follow-up. And I think it's something that the committee really needs to go after, even though it's not the purview of the committee for doing this. It is important in terms of the patient and what to do. And I think we need some more help with trying to get other agencies, such as the NIH, to help us with this problem of how should the workup be done properly, especially for the patients that don't have classic disease, but probably have a problem that can surface later in life. And we don't really have the wherewithal to take care of this properly right now, from manpower point of view, and then also with finances. And I think we need the committee to try to help us engage NIH, et cetera, to be able to do this properly.
Thanks, Jerry. Mark?
Yeah, thank you. And thanks to Kyle for mentioning the American College of Medical Genetics and Genomics. I want to make sure we're using our actual correct name here. Three quick comments about some of the points that were made. First of all, regarding what do we do with positive screening, I would just remind everybody that the ACMG ACT sheets, which are produced in conjunction with and through funding provided by the Health Resources Services Administration, do in fact address exactly what should be done in the case of a positive screen, and also addresses the issues that come up with phenotypes that are identified from screening that may not have medical consequences, like pseudodeficiency and that sort of thing. So there is the attempt, at least, to define some of the phenotypes that are not specifically actionable in terms of the disorder that's being identified, or the purpose for the disorder that is the most severe form to be identified. Now, those are all available and reviewable, and we certainly would appreciate any gaps that are in those ACT sheets be presented to us, because we revise those on a regular basis. And we want to make sure that they reflect adequately the best practices. And if we've missed something, then we want to be aware of that. The second thing is standardization, which is critically important. It's something that we are investing more resources in as part of the Newborn Screening Translational Research Network. We're trying to use standardized terminologies and ontologies. We've been actively engaged with the human phenotype ontology, for example, to make sure that that includes all of the phenotypic terms that are directly relevant to newborn screening, so that that can be more widely utilized. The mention was also made about the need for longitudinal follow-up, which is critically important and is being done with funding from the NICHD, thank you, Melissa, through the Newborn Screening Translational Research Network. But clearly the current resources that we have devoted to that are not adequate to provide long-term follow-up for every disorder. And I think we also need to recognize that there are problems with data access. It's all well and good to be able to get healthcare related data, which is relatively easy to come across. But a lot of the things that we're really interested in reside in different places, like school systems and that. And so how we get at those data to really inform the long-term follow-up question more broadly is really important. And I think it's also important, as we talk about standardization of case definitions and this sort of thing, that it's ultimately the states that make the final decision. So even though we can provide guidance, it's up to the state to decide what they're going to do. And so we need to understand that there is explained clinical variation, which is states have different populations, which means that they may need to do things differently compared to other states to reflect their population. But probably most of what we're dealing with is unexplained clinical variation, which we ultimately need to reduce. And then the last comment just relates to the work of the Laboratory Quality Assurance Committee of the American College of Medical Genetics and Genomics, which in conjunction with sister organizations creates standards and guidelines for testing and that should include newborn screening related tests as well. These are also constantly being reviewed and revised. So for those of you that are familiar with them, if you see that there are areas that need revision that are not really responsive to the newborn screening area specifically, that's something we need to know about so that we can revise those and keep them up to date. And for those of you that are ACMG members, remember that all of those documents go through a public review and comment. And so if you see that notification coming out to say we want comments, please look at them with the lens of newborn screening so that we don't, again, miss the boat on that. Thank you.
Thanks, Mark. Natasha?
Hi, Natasha Bonham, Genetic Alliance. I'm trying to pare down my thoughts. The blueprint is a really great idea in terms of thinking about follow-up. We spend so much time talking about the implementation and then say newborn screening is a system. So I really appreciate that this is moving that to really align with that language and the reality that newborn screening is a system. Did you talk at all about how that effort to collect that information would be supported? We've already talked a bit about today the work that NBSTRN does through NIH funding on the pilot side of things. Whether that's very formal or informal, I don't know, but we know that that is happening and that is such a big infrastructure. Just was there conversation about how you would get to that? Because that is, again, another really big task to put on the nominators, oftentimes who are coordinated by the family organizations. And I think that is right. I'm also concerned from an equity perspective. There are groups that do this amazingly. You know, we know CF has these great coordinated centers. The work that the MPS Society does in terms of short and long-term follow-up is beautiful, but it takes a lot, and not, I won't even say not every group, most groups are nowhere near that right now. So just wondering how that came up in the conversation.
Yeah, this is Kyle Brothers. It did come up repeatedly. I think it's a huge issue. There were several ideas that were generated. I will say I intentionally excluded that part of the conversation from my presentation just because I was trying to focus on what was doable within the context of like the charge that we were given and like what falls into the committee's purview. You know, the narrower purview, not the bigger purview, which I think, you know, was still, there's a lot we could do there. But so I think the one piece that of what I proposed that does touch on that is just trying to get very specific about standard terminology, which is the step one in any effort to collect data. You really have to have standard terminology. But I think we have a lot of work to do on the issue that you're raising. And I think there probably needs to be multiple players, you know, in that very short-term follow-up stage. The states are playing a role, a very active role, because they're really trying to document false positives, false negatives, et cetera, like really trying to just clarify the testing and its quality. But then that longer term issue that would help identify disparities and needs, and also just whether newborn screening does in fact provide the benefits that were proposed for it when it was nominated, are giant issues that I think there's a couple of different possible solutions, but you know, there's all those issues that I think we really need to probably focus on. So maybe I would say to Ned, let's do this thing, and then let's spend a whole round focus on just that mid to long-term follow-up and what do we think is the plan. We need a plan that includes a plan for funding about how we're going to replicate what the CF group has done for conditions that don't have the kind of resources that that community has. So anyway, that's just my thoughts.
Thanks. Siobhan?
Thank you, Siobhan Dolan, Marjorie Dimes. I think that these efforts around the blueprint and, you know, once you get into trying to understand rare disease diagnostic paradigms, treatment regimens is amazing. And so the comment I'm going to make is not at all to take away from that, but to also suggest that there's like some really simple messages of what screening is in healthcare that are really lost in translation amongst providers and amongst the public. And I say this with ultimate respect for the fact that the pediatric and newborn world have something called recommended and uniform, right? Because in the prenatal world, nothing is uniform, there's no benchmark for recommended. It's absolutely the Wild West. But I think that education to these simple concepts, like a screening test is different than a diagnostic test, what a false positive and negative is. I just want to suggest to this committee where it's just like, it's like in the air. We don't even think twice about it. It's such a given to us. But, when you look at that New York Times piece that was written in January of 2022, after this like very bright reporter spent months studying, the way it got translated was you have the screening test and most of the time it's wrong. And you kind of tap into, mistrust, right? And mistakes and that whole world that goes on in healthcare. And I don't want any of our work for, in support of children with heritable diseases to be misconstrued. So I just wanted to point out the idea that in our educational messages, the simple messages around what screening is, you're not done then. It's just the tip of the iceberg. There's steps to take. There's follow-up that's needed. It could help us with some follow-up. It could help the providers understand what they're dealing with as well, because I think there's a lot of, we understand sort of that the public doesn't understand, but a lot of providers I don't think understand either. So I just wanted to suggest that we add, like what we don't even notice, but we add that to a lot of our messaging in the blueprint, in laboratories, and then in professional provider education. Thank you.
Thanks, Siobhan. So I'd like to move on to any additional questions or comments about laboratory, where we talked about the quick start guide and the template work plan that was modifiable by states. And then I would say on a more generic level, how do we take new information about screening technology and implement it through our recommendations? For example, homocystinuria. So comments on those sets of priorities? See, you did a great job, Kelly. So we'll talk more. How about education? Oh, Siobhan, I'm sorry. So the way I looked at education, maybe slightly differently than the summary statement, which was great, was that one, how do we use the stuff that's already there? So that was, and let me just acknowledge the hard work of that group in creating standardized education materials, and recognize it must be frustrating to be asked to create great educational training materials, because we think the job that's been done has been great. And so I think it's more about distribution, uptake, utilization. And then I didn't miss that piece about measurement and accountability. So that was kind of on use the things we already hear. Then there was something new about culturally relevant and tailored educational materials. And so I appreciated the acknowledgement that that's not just translation, but it's actually requires meeting with community members to find out in the specific culture what's important, how concepts like screening or identification or heritable disorders play out in terms of different cultures and different peoples. So I felt that was an important piece. And then I guess the last one for me was getting back to how can we measure that we're having the impact that we want to have. So that was a quick summary that was a little off for exactly what you presented, but that's one of the way I've kind of distilled it and wondered if there were questions or comments there. Yes, Ash.
Took me a minute to think about it, so I'm going to go back to the laboratory standards if you're allowed to. So I was wondering, as we go along, we collecting more and more genetic data on the conditions that are diagnosed. And that may come from second-tier testing or subsequent testing. Is there, how do we in the future use the information from that, as well as from advances in understanding, say, protein structure and so on, to then come back to the first-year testing and use it in a way to further strengthen the initial testing or shorten the time it takes to make a definitive diagnosis?
Well, great question. And I think, oh, I'm sorry, Sean.
I guess I just would like to ask you for some clarification, Ash. Is it, are you asking, is there a mechanism for sort of revisiting conditions that are on the RUSP to say, are we doing, you know, is it, should this still be on the RUSP? Or more importantly, is there a better way to do it? Is there new testing that we could, that we should be recommending that would make it more specific and reduce false positives? Is that the question?
Right. So using the, I think it's primarily the genetic information from the polymorphisms or VUS and all the other information from that, as well as combining that with, I think, with the protein structure information to see whether that information is being used to go back and evolve the initial testing in some way. Is there a way to utilize the information that we are collecting eventually with second-tier testing?
I may be speaking entirely out of turn here. I don't. I don't think there's a. I don't think that we have a specific. I don't think there's anything that would prevent this committee from going back and asking those questions and looking at new data. But I also don't think that there's sort of been a systematic, and correct me if I'm wrong, anyone, but I don't think there's a systematic sort of policy or even tradition in place of doing that. It's certainly something that's been discussed in the past, and I think it's come up again in this meeting. You know, should we like have programmed reviews of conditions that are currently on the RUSP? The evidence review group is groaning when I even mention that idea. Oh yeah, no. Just for the record, Alex Kemper is indicating bring it on, I believe is the so yeah, maybe that's something that we should be thinking about doing sooner rather than later. Dr. Warren, how much funding can we have to do that?
The staff are furiously taking notes, as am I, and we will continue to think about how we can make resources available. Appreciate that.
Karen?
That was a good answer, by the way.
Karen, can you unmute and?
Sure. Thank you. I was not quite sure where to add this comment. It really applies to all the different groups, but it also links in with the excellent presentation by Dr. Kaur. So what I want to bring up is that we've talked about, equity and looking at healthcare systems and looking at systemic racism and structural racism. And I think we have to be a little bit more explicit across all domains. DEIJ needs to be the lens with which we look at things. And one thing I found missing in the excellent discussion around family-centered care is really a little bit more self-examination of we as healthcare providers. How is our implicit bias affecting our interaction with families, for example? Are we aware of our own implicit bias? Are families still feeling stigmatized by the care that they receive in the healthcare system? So that's one point. The other is structural and systemic racism, by definition, is somewhat invisible. And how can we make the implicit explicit? How can we look at historical approaches to addressing some of these genetic disorders, and how can we really think about how is structural and systemic racism explicitly playing a role in the field today, and not just within the newborn screening, but across all services for children and youth with special health needs. So I think that really applies to each of the subcommittees. And I know that it really came up in our the subcommittee I was listening in on, the education and training, but I also think it's very important in the follow-up and treatment work groups as well. So I hope we can take the blueprint that was presented this morning and take it just one step further to be a little bit more explicit about what we mean by centering families. And following on what Natasha said earlier, families have been very vulnerable. I think we as providers or as state employees or as professionals need to be very vulnerable as well, and look at our own biases and how we may inadvertently contribute to some of the less than ideal experiences that families may be experiencing.
Thanks, Karen. Mark?
Yeah, I want to really endorse what Karen just said, and reflect on something that we heard yesterday about how newborn screening really provides the opportunity to objectively identify individuals irrespective of pre-existing bias. I think the severe combined immunodeficiency is a really phenomenal example of how instituting a screening program really changes what we thought about a disorder that was really considered to be primarily a disorder of Northern Europeans, until we initiated screening and then found that 80% of the cases actually occurred in individuals of non-Northern European descent. But the thing that then needs to follow on, that Karen has appropriately highlighted, is but now that we've identified this, and we've identified that this is really a pan-ethnic condition, is the access to services that are needed to appropriately treat those individuals being provided in an equitable way? Or are we now again seeing inherent bias and the systemic racism interfering with the appropriate treatment? So that's the next piece that needs to follow on.
Thanks, Mark. So I appreciate the rich discussion, and I think as I met with folks during a break, we decided our next steps moving forward is to come up with a priority for the work groups to work on for the next year. So this is our last meeting of the year, and our hope is to take the work you've done now in the work groups over the last 2 meetings, and let's move forward in just some very specific issues. So in the education and training issue, we did learn that there likely be resources available for additional dissemination and awareness building around materials that already exist. So we kind of drop down to the next one and think about how the work group could think about who to engage in the creation or the modification of the training and education we currently have to bring in that issue of diverse and cultural awareness, and how to make the training in specific subgroups of our population who are traditionally overlooked or marginalized more effective, and that information distribution be more equitable. So that was our charge, if you're willing to accept it, Jane, to education and training. For follow-up and treatment, I really liked the secondary condition, and I thought the best part, this place to start though, would be this blueprint for follow-up and treatment. I'm sorry, let me go to laboratory standards. Really going down to creating this guide and project plan for us implementation. So the quick guide and the modifiable, I like the way you said shell. So the elements that, so one, the elements are so diverse, but helping a state laboratory think about, can I use the machines I have? Or do I need a new machine? If I need a new machine, what kind of footprint does it need? What kind of staff and expertise does it need to run it? If I'm going to add molecular testing, who's going to interpret those tests? And if it's not us, who are we going to send it to and develop those relationships with? So actually thinking about building out both what would need to be in the quick guide and what would need to be wrapped around in the shell is the kind of 1 year a challenge and charge I would like to give to laboratory standards and procedures. And then finally, for follow-up and treatment, we love this idea of the blueprint. And so the charge would be, can you actually think about what elements need to be in there? I think, Natasha, I wanted you to know, for what it's worth, I had real worries about saying, let's have the nomination folks do it. It's a complex issue already. And now that I've reviewed a couple of nominations, I realize the challenge that we've given the nominating groups to do and the dialogue. And so thinking about, are there things that we're already doing that could help feed that? So then, Alex, I thought about you, because you are bringing experts in treatment and follow-up together to talk about the evidence review. And so if we could at least, and maybe working with our colleagues in the nomination space, think about, is there any expansion we could add to a very small section in treatment and follow-up, but really make that part of the ERG, because you're finding it out anyway. And could we kind of think about taking that treatment information and the secondary testing and all that out and helping flesh out that piece through the treatment and follow-up work group. And we thought you could even start with building the methodology with something existing like SMA, where we, states had to go through all that process. So that was my challenge to your group, and it felt discreet and actually doable. And I had one other point, and I'm trying to remember what it was. And so then the last thing, Kelly, around implementation was timing. And we wondered if, as the information from ERG about the tests and the secondary testing and how you go for a screen to a diagnosis, as that comes out of the ERG, could we start working with CDC and other partners to already start devising the laboratory quick guide and worksheet for implementation of the test itself? And the idea would be that we would send the recommendation to the secretary and have enough developed so that, assuming the secretary approved the condition, that the guidance for how to do it could come out at the same time. So now you have this coordinated, you have to add this, and this is how you might do it, or the considerations. And I think that's true for treatment as well. We heard some group that the state says we have to start working on it as soon as the committee approves it. And that's the wrong decision point, right? Because it's the secretary who adds it to the RUSP. We just make a recommendation. And so if there could be a coordinated approach of we're adding it and here's some guidance on how to do it, that I think would make the burden on the states may be a little more palatable and maybe decrease concerns that the secretary's office might have on the burden that we're putting on states in terms of implementation. So that's what we came up with for 3 challenges, 1 to each work group to work on for a year. And I would open it up to thoughts. Scott, I see Scott's raised his hand. Oh, I'm sorry, Sean.
I'm already got my card. I never turned my card down.
Okay.
I guess I'm talking too much. Could you just remind us of the resources that are available to the work groups to support this effort?
Well, yes, what we have for you is staff that will help find a time that everyone can join. And then Zoom resources available for you to get together to use. I do want to tell you that I think information flow from the ERG is another thing that you can have to work from. But I'm hoping that creating at least the shell or the overall framework, weaving it from your own expertise and from whole cloth is a challenge that would be reasonable to give work groups over a certain number of meetings between now and this time next year.
This feels a lot like when the dean tells me that my salary for teaching in the School of Medicine is the honor of putting that on my CV. So thank you for that.
Well, you know what I'm going to say is the overall contribution to population health through your work. I guess the other thing I do want us to think purposefully about is a resource issue, and recommend that our committee charge is a bit broader than make recommendations about the rust. I think if we have concrete suggestions around budget to support state implementation of new conditions. First of all, let me tell you, I really am so thankful to Michael and to the Bureau for what they've already contributed and brought to the table. And I don't think that keeps us from asking for more. And I think thinking about how to do that in a specific, structured, logical way is something I would like to discuss with the members moving forward, because I don't think there's anything in our charter, which will get renewed, or the legislation that created the advisory committee that would keep us from saying we have a specific recommendation about resources to help improve implementation of our recommendations. So does that help a little bit to answer your issue?
It does, thank you. And I think just recognizing that there's, that it's okay to call on the supports, that the administrative support staff, and ask questions to the ERG as the process is happening, probably does take a little bit of burden off of the work groups. I don't know, but any other work groups have thoughts about that? I think some of these things are very, it's easy to invest a lot of time in some of these activities. We just have to be cognizant of that.
And I recognize that, John. I would just say a couple of things. We're always very enthusiastic about what we can do when we're sitting here in Washington, away from the other requests for our time. And then the recognition that all of you do this within the margins of what I would call your discretionary time, which is split between professional and family. And for what it's worth, I just really thank you for doing that. And if there are ways we can support you and make it more manageable, and I'm using that global we, that's not me, but the Bureau and other folks, you just need to ask and we'll see what we can do. That makes sense? Yeah. So thanks for that. So this is that wonderful 5 minutes that I actually can tell you I don't quite understand, which is there any new business for the committee? Oh, and I'm sorry, Melissa.
I just wanted to make an announcement to everyone with an interest in newborn screening And that's that the NIH has an open request for information for feedback about future research needs and infrastructure support for newborn screening research. It's technically open until midnight tonight, but we will be kind and leave it open for a few extra days. And if you have some burning feedback that you'd like to give to us, we would be very interested in hearing it. So if you want information about this, all you have to do is go to Google and type in NOT-HD-22 for fiscal year 22 -042. So one more time, that's NOT-HD-22-042. And we'd love to get your feedback on research and the infrastructure, the Newborn Screening Translational Research Network, and ways in which we can support research in newborn screening. Thank you all very much.
I pasted it in the chat.
Thank you.
Scott Schoen, I'm sorry, I didn't mean to not call on you. I admit that I was staring at the clock and not at my screen. So Scott?
That's fine. I appreciate Scott Schoen at ASTO. So I just appreciate this second. I would just ask Ned that as the work groups work on their charges, to one, be very cognizant that some of this work is done by partners, and to look into that, to not have to reduplicate efforts, especially with the resource discussion that Sean just brought up. And I will say, Sean, I was once told that there are intangible benefits of the job. So I would also ask the members of the work groups to look back at the presentations over the last 2 meetings, because I feel there are some things missed from presentations, particularly some great discussions yesterday from my colleagues around the country. I want to highlight Dr. Zori's comments about looking at, are we doing, I think we talk about this a lot, but are we doing the best with what we're doing? And just continuing to push forward without reflecting on the past is going to continue to put us down a path of not learning anything except how to build more challenges for us. And so I would ask that in addition to all the challenges that the chair just shared, is that a review of the presentations and the minutes from the last 2 meetings and all the thoughtfulness that went into those presentations on the challenges of the system and the overlap of public health, medicine, and that intersection of newborn screening are going to be very necessary to address the challenges that were just laid out for the work groups. And I appreciate the moment, Ned. Thank you.
And I appreciate your comment and the work you put in to those presentations and before. So is there any new business before the committee today? Seeing none. Oh, Natasha.
Sorry. One thing that's come up that I don't think this committee has discussed recently are the lawsuits that have come up for in newborn screening. And that just may be something to get on the agenda for 2023. There have been a couple of really great presentations, many of them including Dr. Erin Goldenberg, that I think could be really informative to this group, just to make sure we're thinking about what the public is also hearing about newborn screening, which unfortunately tends to be those topics that hit the headlines like lawsuits. Thanks.
Thank you.
Can I just add a comment to that? You know that I'm very concerned about potential harms of newborn screening that we don't have any way to, that we really don't have a way to measure. And I've said several times before that nobody speaks for people that are experiencing the potential harms of this population-based compulsory newborn screening program. And I do think that those families that Natasha is referring to are those people. Those are the voices that we need to hear. So I just want to second her request to put that on the agenda for future discussion, because I think those are voices that we need to hear. And I wish they would come to us instead of going to the courts, but maybe we're just not on people's radar in that way.
Thanks, Sean, and thanks, Natasha. So our next meeting will be virtual, February 9th and 10th of next year, which is right around the corner. You can look at our other meeting dates on the website. They're available through 2025. And with that, I adjourn our November meeting and thanks to everyone for participating. I thought we had a good time. It was so nice to be in person. We'll see you next time.